Good morning, everyone. I'm not sure. We'll probably have some late arrivals, but we're going to get going. My name's Lisa Konechny. I think I know many of you. I'm the coordinator for the NF Clinic here at Children's Hospital, Wisconsin. So on behalf of myself and the NF Clinic team, we'd like to welcome you to today's program. I'd like to recognize and thank the Children's Tumor Foundation for sponsoring this event. Today's presentations are being videotaped for expected future use on the CTF website. Audience members will not be pictured on the videotape, but your questions will be. I'm going to quickly mention that the folders you received at check-in contain tools and resources related to today's topic. The Children's Hospital Wisconsin Clinic staff are identified in the binder also. You're going to meet many of our staff as they introduce our speakers, but I want to recognize our NF Clinic co-directors, Dr. Dawn Siegel and Dr. Donald Basil. There are evaluation forms with the materials. Information from these evaluations are going to aid us in future programming, so please return completed forms to the registration table before lunch. The nearest restrooms are located just outside the auditorium area, and at this time, please remember to silence any electronics. I want to offer some background as to why we chose this topic today. Our daily work with pediatric patients prompts us to recognize that at some point they'll have to move on to adult care. This can seem scary and overwhelming to patients and families with concerns about whether a teen is ready. This is especially important as it relates to a lifelong chronic condition. Today's speakers are going to address the developmental needs and challenges of teens with NF1 and identify tools to assist teens and families as they prepare for transition. You'll also get a glimpse into adult care. And with that, I'm pleased to introduce our first speaker, Liz Horning. Liz has been a social worker with Children's Hospital of Wisconsin for over 13 years, working in a variety of areas throughout this organization, the ICU, ER, Child Development Clinic, and International Adoption Clinic. She's specifically been covering genetics and neurosciences for over 10 years. Her role at Children's covers everything from birth to death and everything in between in terms of supporting families and children with special health care needs. Prior to joining Children's Hospital of Wisconsin, she was the Director of Adoption Services for Lutheran Social Services of Wisconsin for 5 of the 14 years that she worked for that organization. She notes that she had the great pleasure of working with children from around the world and bringing children and families together through adoption. Welcome, Liz.
Good morning, everybody. Thanks for coming on your Saturday morning, bright and early. So we're going to and please feel free at any time to interrupt, ask questions. This is more of a discussion. It's a nice small group, and so let's kind of keep it in that fashion. Wow. There we go. You can tell often I do PowerPoints. So really we should probably start off by asking the question, what is transition? And a lot of people have a lot of different ideas. Where I get my information from and the definition of transition really comes from one of our most trusted sites, and that's gottransition.org. So I would encourage you to kind of write that as a resource, as an opportunity to go explore that site at some further time. It has a lot of great information, but this is the definition that they offer. Healthcare transition is the process of getting ready for healthcare as an adult. We often don't think when we're in the children's world that we're ever going to move to the adult world. It's kind of a nice area to be in, but at some point we need to transition families and children to the adult world. During childhood, parents usually help with medical needs. They call for appointments, fill out forms, and keep track of medications. As you get older, managing medical needs becomes their own responsibility. Typically, this in Wisconsin and most areas is at that magic age of 20 or 18. And here at Children's Hospital, we will kind of recognize that individual at 18 as their own adult unless there is a guardianship in place. Achieving independence requires an organized transition process to gain independent healthcare skills, prepare for adult care models of care, and to transfer to new providers. And I think as the team offers some of their information as we go through the day, you're going to get some tools to help you transition through this time. There are several steps you can take to make sure the transition to adult care goes smoothly. And that's kind of our role as both parents, providers, and you, the patient, to make sure that that's a coordinated effort to the best that we can. So in the pediatric care world, we are child and family focused. Everything that we do here at Children's involves both the patient, the parents, and we as providers. And so we really look to the parents to guide us, as well as the providers to help with implementation of plans, and certainly for the patient as they mature to offer their own advocacy into their health care. But really, it's really parent driven and provider recommendations. We always have parental involvement to ensure compliance. Part of my role in the social work arena is certainly to aid in any of the obstacles or barriers that kind of limit medication or medical management compliance, whether that's transportation, whether that's medication, insurance. There's a whole host of things that I become involved with the family when there are barriers in place to providing optimal medical management. And I also participate as part of the multidisciplinary team. So not only do we have attendings, we have nurse practitioners, we have genetic counselors, sometimes there's nutritionists, there's dermatologists, there's me, the social worker, and then anybody within the clinic setting. So we really try and provide a multitude of people to help support you and your family through this process. As transition happens, as you get closer to the magic age of 18, we become probably more aware that we need to get you as the patient and you as the parent kind of engaged in the process of, you know, how do we get you prepared for the adult world? Because we know in the adult world, it's no longer likely family focused. I have yet to meet an adult provider that includes my whole family in my medical management. It's really just me. I think the only thing they ask is when there's an emergency, who should you contact? And that's about it. But as youth transition to the adult world and there is a special medical need that we have to be considerate of, how do we make sure that everybody is prepared when it becomes the patient that's the center of the care in the adult world? We want to make sure that they can gain some autonomy and independence, advocacy, awareness of what they're going to be asked, how they're going to be asked to do it. I mean, simple things like where you need to park, who you need to call. These are all really important things as they mature into adulthood. And this is often physician-directed care. This is not family-centered care. So that's going to feel different, and probably the engagement is going to feel different as you enter into the arena of the adult world. It's going to feel different than when you step into Children's Hospital world, where we have bright colors and, you know, we have dogs roaming about for therapy. We have lots of different things here. You're really not going to see that in the adult world. So we want to make sure you're ready. So really, at what point does transitioning begin? And if we look at the American Academy of Pediatrics guidelines, they offer that transition begins at the age of 12. For most people, that's pretty overwhelming to think, oh, I'm ready to, you know, start this process. And I think the key thing to consider is this is a process. This is not something that happens overnight, and it's years in kind of the making, if you will. It used to be the American Academy up until a few years ago offered that 14 was the magic age that we start, and then they dropped it down to 12. So really at 12, some of the things we're actually engaging you with in our discussions throughout your medical visits are really some of the questions that we're asking about transition. Where, you know, do you know where you are? Do you know why you're here? Do you know your medical condition? Do you know medications that you're taking. Oftentimes at 12, you might not know kind of the dosage, but these are things we build on over time, and it's part of the parent, the patient, and the physician and their multidisciplinary teams to engage you in that process, okay? I think actually in your packet there is a tool sheet that offers information about transition readiness that the NF team has put together. So I invite you to look at that at some point. The one that we use within our medical record here is considerably more extensive, but I think that that's a good starting point. Checklists help us stay on tasks and in terms of what we can do to help you get ready. Things like making sure we review at each medical clinic appointment kind of steps that we need to take in terms of your medical care. Medications, if there's any recommendations for follow-up appointments, why we're making those appointments, who those specialists are. We want the patient to be engaged as much as the parent in asking questions, offering opinions, and kind of gearing them towards their own self-advocacy. And this really starts at that, it starts much younger, but quite frankly at 12 they offer that we really want to make you more participatory in that process. What are some of the benefits? Well, certainly everybody becomes more knowledgeable. And what we really want is the patient to be more knowledgeable as they begin to age along in life. They're going to be adults in a shorter period of time than we think and hope, but the plan is that we gear them up for their own self-advocacy. And I would say that by the time they're 18, 21, not everybody transitions at the age of 18. I think it's more often, it's probably between 18, 21, 22, and that's really based on the clinic that you're in, the providers that you're seeing, and their multidisciplinary team to consider when you're appropriately ready. We want you to be more independent, self-confident, and self-sufficient as you bridge that gap to transfer your care. And really, for our adult providers, their expertise is in caring for the patient, not so much the whole family. So it's a different approach than we have in the pediatric world, where we really do probably take care of the whole family as in terms of what we do here at Children's. I can't speak for every hospital, but I would suggest most children's hospitals really, it's a family-centered approach. And in the adult world, it's a little bit different. We want you to be knowledgeable of everything that pertains to you, your chronic medical conditions, the implications of your illness, where to obtain more information. In some of the packets that you received and in your bag, there's information about how to get medical records. This is also a very cumbersome process in many hospitals, and not everybody knows where to go, what to do, even what the form looks like, who fills it out. And every area, it's also different how it looks. So it gives you a glimpse into how the process can work for you by just kind of giving you some tools to look at before you actually need to do that. The internet can be a great source of information. It can also be a great source of distress. So for use, there are some suggested websites through the NF Foundation, NF Tumor Foundation, that offer some really good resources both on their website, and I would even recommend asking your medical providers what trusted sites they look at to get additional information, not only about transition, but more about your specific medical condition. Other things that we want you to be engaged in learning about, symptom management, daily care. Are there some things that you need to do each and every day, or are these, every 6-month appointments? Who do you call? If there are symptoms that come up, who's your contact person? After every visit here, your parents get an after visit summary. In the adult world, you'll get that too, but it's going to be your responsibility to know who you call when there's a need. Not so much a crisis, hopefully, but a need. But you need to know who's that contact person And how long should you wait before when you call, send a message, and you wait to get a response back? These are really good things to practice as you transition into that adult world. Learning your medication management, who you get your refills from. Do you go to Walgreens or do you come to Skywalk here? Or in the adult world now, are you at the Freighter pharmacies? So, do some planning around those types of things. Remember, you're not going to maybe have your license right away. If you're one of those late bloomers like me, you rely on your friends or you rely on your parents. For some of you, it's going to be 16 and you're going to be out the door in your car and doing your own thing. But, if you need to fill your medications and you're starting to be responsible for that, and parents are still around when you're 16, 18, they can help you, but they may be wanting you to take some of the lead on these things. Okay? So you got to know how to do these things. Scheduling your own medical appointments. Well, sometimes you need moms and dads to kind of come with you to be that listening ear. Or you want that because you want a second set of ears to listen, to take notes, to remind you of things that maybe you didn't catch during that appointment. There are ways to do that. If you schedule your appointment and you want your adult parent to come with you and have information about you, you can sign a release of information at the adult care hospital so that they can obtain medical information, help schedule appointments, maybe run interference if necessary. But if you don't have that release on file, they're not going to give your parent any information. They're only going to talk to you. So these are some things that you're going to need to think about as you kind of make your plans for that transfer to adult care. For some people, they want to interview who their providers are going to be. We get that a lot when it's your parents interviewing providers for your health care. They want the best for you. I tend to think we have the best. But in the adult world, you're going to be responsible for who your provider is going to be. We're going to give you some recommendations, perhaps, if you live around this area or around the state. But let's say you don't click with that person. There's a personality kind of conflict, or they're not getting you. What do you do in those circumstances? So those are things we want to help you prepare for. Who is another adult provider in your hometown that would know your medical condition, or in a neighboring town? Or are you willing to drive so that you can have a provider in a different area? Really complex things sound easy, but we want to make sure you know how to do those processes, okay? You're still going to need a primary care provider, whether that's an internist, family medicine. You'll have your specialist, but you still need a primary care provider. In the children's world, we call it a pediatrician. In the adult world, it's called something different. We tend to think our pediatricians kind of end when we're about 18 and then they transfer us to the adult world. They want us to see adult providers. We have adult things going on in our care, so there are some specialists in that arena outside of your NF specialists, okay? So we have to be considerate as we transition to almost that 18-year age, who will be that next provider for general care, okay? Health insurance. This ebbs and flows because we have some great things that have happened in terms of healthcare coverage, and for young adults, they can be on their parents' insurance until they're 26 years of age for most healthcare insurance plans. For others, there's options through Badger Care, which never used to be an option, but in the last 5 years it has changed to include childless youth through 18 through 59. So that becomes an option at age 19, 18 into your 19th birthday. You become your own adult household in the eyes of Social Security and in Badger Care world, where they're income-based programs. So these are programs that you can, if you have questions about, certainly ask the social worker in your clinic as you get closer to that age 18 years, and we'll kind of figure out what options specifically would be available for you. But know that there's some good plans out there. We talked about making calls when there's questions or concerns. For some families, as their child transitions and transfers into adult care, we kind of make a list of who their providers are. In the pediatric side of things, it's probably posted somewhere in your home for a babysitter or whoever is taking care of your kids when you're gone. It's not unusual that we could tuck that into your wallet or into your purse when you're in the adult world, when you become your own adult and in charge of your own care. You have to know medications and all those things that we talked about before. But quite frankly, at a moment's notice, it's helpful to have a toolkit, tucked up either on your refrigerator, in your wallet, something like that, so people would know, and you would know you need to hand it over to your provider when they ask you those pertinent questions. You need to carry your insurance cards if you're on your own insurance. And for some youth, as they transition into the adult world, they will be the sole owner of their own health care. They may not fall under their parents' health care. So it's important to get that card and tuck it in your wallet. It becomes as important as your debit card or any credit card that you're going to carry as you turn to adult years. And then many of you will go on to something called college, university, that great life before you become the person in the working world. I happen to think that this is the best time of your life. Minimal responsibilities. You take care of yourself, you take care of your college needs, your courses, which is a lot, but hopefully you won't have to have a full-time job and you'll be focused more on your college experience or wherever you decide to go post-secondary. For some people it's not college, for some people it's into the working world. Some people use Department of Vocational Rehabilitation. High schools tend to utilize these programs. In the adult world, we try and utilize these for kind of discovering what may or may not be an interest of yours, short-term and long-term. For some youth, they really don't know what they want to do. Rather than waste money at college, it's an opportunity to explore different opportunities for job experience. They can offer mentorships in different areas so that you get the experience, you have a coach with you, and you get to provide feedback on, is this the right opportunity for me, or do I need to continue looking for something? And then you can, if it's continuing to look for something, they give you a new experience based on conversations and discussions with you and kind of what your interests are. Every county has a DVR, or Department of Vocational Rehabilitation program, along with what's called an Aging and Disability Resource Center, which is not on here. It's commonly known as ADRC. Aging and Disability Resource Centers offer consultants for short-term and long-term care. They also offer Department of Vocational Rehabilitation. They also offer a host of things for guardianship, transition planning, community resources, and different opportunities in the adult world. You can become engaged in DVR and Aging and Disability Resources somewhere along the lines of 17 years, 9 months. As you launch into that 18th year, you can kind of engage in those programs to kind of get the lay of the land, see what's offered, and see if this is opportunities that you wish to take part of. Not everybody wants these opportunities or needs these programs, but it's available for all individuals, 18 to 59. And again, you can start getting engaged in those programs somewhere around 17 years, 9 months. If you're a person that's going off to college, there are student health services offices that are available to you as an immediate resource. There's pharmacies on most campuses. There's emergency contacts that you can have on campuses, but you want to make sure if you're living in the dorms that your roommate as well as your resident assistants or RAs know about these people in your life and maybe your medical condition to a certain degree so that they can help support you if there's an urgent need. Sex, drugs, rock and roll. I mean, that's college life in some areas. Some people are more studious, but these are things that are going to hit you that may have not hit you in your children's world, but in the adult world, you're going to see things on campuses and have experiences that you probably may have never been exposed to. Some high schools may have this, but I tend to think this happens more in college when you really get ingrained to different cultures, different people, different experiences, and you're on your own trying to manage all these things that are coming at you. And you have to know what to do, where to go, who to talk to if you need help or encouragement, or, someone to have conversation with if the need comes up. Individuals as they transition and they're turning 18. For most individuals, you move through life and you don't think about advanced medical care directives. If you work in a medical setting, we think about it quite frequently. Especially in my role as social work, as you turn 18, you want to make sure that everybody has advanced care directives. What happens if? Now, whether you have a medical condition or not, this is something we should all have. So, I'll be the first to say I just did mine when in the last year. But it's something that we should all have in the event of something untimely happening to us where we can't make medical decisions for ourselves. At 18, you become decisional and you can set forth what you wish as far as if you can't make medical decisions. Do you want breathing tubes? Do you want nutritional care? Do you want to go to a nursing home or a rehab facility? These are really big decisions. And for youth transitioning into the adult world and having to consider making big decisions about what they want if something were to happen, takes some time, some conversation with their parents, some self-reflection about what is it that they want for themselves, okay? I have copies of these if you want to take a look at them. They're state forms, so you can print them off the internet on Department of Health, Wisconsin Department of Health website. But I think it's really good kind of in that transition process that you begin conversations about this moving towards that 18th year. It's not to say it's a hard and fast rule that at 18 you have to have these on file. Absolutely not. But it's good to have conversation around it. So as parents, you know what your now adult child would like at that point in time. It may change at some point, and these can be updated at any point in time. So what you decide at 18, at 32, you may have something different, but they can be updated, and you provide it to your medical care providers or the institutions or organizations that are providing medical care to you, and it would be in your permanent medical record, okay? But I think it's interesting to review what is all in this. For some individuals, making decisions is something that not everybody can do at age 18, and they can't be their own decisional maker. And so there is a process called legal guardianship that for some families we can assist with here through Children's Hospital Pro Bono Clinic. For others, they would do it either through a private attorney or through their county program. But for individuals who at 18 who are not able to make decisions on their own, or they need the support of a parent or family member that they have designated, it becomes a legal process to do guardianship. So you designate somebody to help make decisions on your behalf or in conjunction with you. You do need to go to court for that. It is something that you then send to your medical care facility so that they know when that individual comes to their clinic, not only who the decision maker is, but what decisions they can or cannot make. And it's spelled out in the guardianship documents. So things that are on that legal guardianship form, it's an 8-page court document, but it asks questions everywhere from, can you consent to organ donation? Can you consent to marriage? Are you able to obtain a license? And they qualify licenses as not only driving, but it's hunting, fishing, and any other license. So it's all one category. Can you consent to research studies? So these are big decisions that each individual is able to make. For some, those are decisions that they can't make on their own, but they need support from either their parent or extended family member. But it is a legal process and you do have to go to court. So, for transition resources, I've mentioned .transition.org. That's okay. That is a wonderful resource. That's okay.
I turned it off, apparently the video wasn't on.
That's okay. GotTransition.org gives a whole host of information. It's an excellent resource. I encourage you to look through it. American Academy of Pediatric also has information on transition. Much of what we talked about today, or you listened to, but also some different aspects of things that we didn't cover today. Family Voices of Wisconsin. I utilize this resource a lot just for informational sheets. It really breaks down program-specific type, like for some families they want Social Security. For other families they need a personal care worker. These are things that on a fact sheet are spelled out really nicely, and it gives a step-by-step process. They have fact sheets that you can print off. They have publications. They have resources. Support groups in and around Wisconsin. The Department of Health Services offers some information. Their website's a little cumbersome, but I do have printed off the Power of Attorney for Healthcare, which I think is one of the most important pieces of information that I draw off that site. I think the other would be, and I don't have it with me, is your medical transportation for those that have Medicaid coverage as a primary or secondary. Transportation becomes a significant issue both in the children's world as well as in the adult world. And how do we navigate getting you to and from all your medical appointments? If you're a Medicaid recipient, whether it's primary or secondary, the state offers some insurance-funded resources for transportation, no matter where you are in the state of Wisconsin. We don't want you to be caught up in, I can't get to medical clinic appointments because I don't have transportation. So the state has offered that if you're a Medicaid recipient. So those are just a few things that I offer as part of your transition process. Are there any questions? One and then the other. She's right behind you.
Okay. My daughter is 19.
Okay.
And how do we get the providers to treat her as an adult? Because she actually had an issue that was noted in her appointment, and then, you know, it said if she had pain, she should contact them. It said they'd get back to her in 2 days. It was 3 days instead, and then they just kind of brushed her off. And I had read her note that she had sent to the provider, and, you know, it was very well thought out, very well worded. It sounded very adult-like, and yet she didn't get a response, and then I had to step in.
Okay. Did she send that note through MyChart?
MyChart.
Okay, so she went through all the proper channels of how to send it. Did she get a response back after 3 days from the provider, or was it from a nurse or someone that?
The provider that she had contacted.
Okay. When she had her conversation with the provider, did she bring up any concerns related to that specifically about what can I expect from you in terms of an appropriate response time? Some people offer that on their emails, or when an email or voicemail is returned to you, like we'll get back to you within 24 to 48 hours. Was that ever offered as part of?
On the MyChart, it says we will get back to you in 2 days.
Okay.
Or 48 hours, and it was
3 days.
yes.
Okay. When did she address it with the provider? On the phone call when he or she returned
There
it?
was no phone call. It was just a MyChart response back.
Okay.
And then when I stepped in, then I got a response back, a call back.
Certainly, I mean, you could, my suggestion would be is to address it with the provider itself first. I always like addressing it, do you have an upcoming clinic appointment at all, or does she?
Not for a while.
Not for a while. You could address it in a My Chart request, like, here's my concern. When I've reached out to you, you've indicated there's a 48-hour return time. It took 3 days and intervention from my parent to get a response. I'm wondering if this is per your protocol, that it was more like 3 days, or if there's somebody else I can talk to. Now, certainly you can go up beyond that person and go to the clinic manager or something, but I really try and address it with the provider first.
And that provider did say, oh, I'm sorry, it slipped down on my list. You know, and that was all it was. It was
Right.
very frustrating, and she was concerned about what she had going on, and
Absolutely.
didn't get a good response.
And is that her primary care doctor?
No.
That's her specialist?
Yes.
Okay, so she needed to talk to her specialist. It wasn't something she could go to her primary care doctor? Okay. I would really try, I mean, obviously that person was apologetic, but I would just make sure you address it during your next clinic appointment so that they know that you're trying to be a diligent person and addressing your concerns when they come up. If the expectation is a 2-day return, then that's what I'm going to expect of you. I will wait the 2 days, but I guess what happens at day 3 if I don't hear from you? And hopefully they give her some clear guidelines, because maybe there's an urgent line she could call into for a nurse to return a call or to get another message to that provider. So I think there's a couple different ways they may offer a solution if it's still urgent and they didn't get a response to you. So, next question.
I just, the prior page, the FMLH, what does that stand for?
Oh, Frederick Memorial Lutheran Hospital.
Oh, okay.
The big house next door. For those that are in the Milwaukee area, I guess I will clarify. No, it's not some grandiose place. It's
Thank you.
the big house next door. Other questions related to transition, to power of attorney for healthcare? I answered all your questions. Okay, very good.
Do you want to clarify that there is limited guardianship and maybe describe a little of that?
So what Lisa asked is, for guardianship, it's not all or nothing. Like, you don't, if you're non-decisional, it's not that you have to kind of transition or transfer your guardianship to one person for everything that you want to make decisions of. There is limited guardianship, which really offers that there are some decisions you can make with the support of your guardian or on your own. But each one of the questions that the medical provider has to address, and there are, I think, somewhere like 50 questions roughly, each of them different and related to different topic areas. It could be marriage. It could be, are you eligible to vote? It could be, are you able to get a divorce? Are you able to consent to organ donation? And there's a whole host of others. Some of these are going to be decisions that perhaps you could make on your own. Again, maybe they're ones that you need the support of somebody. That would be limited. You're going to make them in conjunction with your identified legal guardian. But each of these can be limited or full, meaning somebody's going to make them all together and you have no say, or you have a say and it's going to be supported by your guardian that you name. Does that help answer that? Any questions related to the guardianship piece? Okay. Yes.
Is there like an ongoing list of adult providers around the state that people kind of manage?
I will let the medical team address that because they make more of the recommendations for providers and transfer of care. Will one of you address that?
Sure. Depends on how far around the state. Around the greater Milwaukee area, we definitely have identified providers. Beyond that, it becomes a little bit more challenging.
But if you're in a certain area and you want to go to a certain provider and you want to have somebody take a look at that person's profile, I'm sure our medical team would give you information about that individual if they had the chance to review credentials or their area of expertise.
I was specifically referring to specialist centers. There's a specialist center in Madison, there's a specialist center here. But beyond that, I'm not aware of some other specific specialist centers.
All right, thank you.
Thanks, Liz. That was fabulous. Okay, it is my pleasure to introduce Kyra Gray, who I've known for quite some time. And Kyra is a young woman with NF type 1 who has successfully transitioned from pediatric to adulthood. She's 23 years old and received her Bachelor of Science degree in cross-categorical disabilities with an emphasis in intellectual disabilities from UW-Whitewater. She currently works at the West Dallas, West Milwaukee School District in a self-contained intellectual disability elementary school classroom. So doing great things there. Hopefully we'll hear a little more about that. I'd love to. So Kyra's here today to share some of her experiences and tell you how she's kind of overcome some of the challenges as she has faced during her NF journey into adulthood. So help me in welcoming Kyra. Thank you.
All right, so I'm going to open up my PowerPoint. Thank you for introducing me, Heather. There we go. So how I have successfully transitioned to adult care. This is who I am. Kyra Gray, as Heather said, 23 years old and a teacher. The past 2 years I've been teaching in an elementary school. My first year was with students with severe behavioral challenges and autism, and this year it's intellectual disabilities as well as autism. And I first just want to talk about self-advocacy and education. When I was in 5th grade, I was diagnosed with dyslexia as well as an auditory processing disorder. And with that, though I did not qualify for an IEP, I did qualify for a 504 plan, which my mother, who's in the audience, helped create with the teachers, get what I needed. The plan didn't just focus on my dyslexia needs, but it also focused on my mobility needs. So there's times where I'll need to wear orthopedic braces on my legs or needed more assistance in gym class, transitioning from classroom to classroom as I got to middle school. And that's something I really focus on with my students as well, is to advocate for what they need. So even though I'm working with ages 4 to 11, saying, hey, Miss Gray, I need help, and then whatever they need help with. Teaching them and to go into their adulthood, to not be afraid to ask for help, not to be afraid to ask for questions. So if they need a certain device in the classroom, they can ask me. And then as the teacher, it's my job to talk to someone who can. So if your child needs something now, they can talk to you. As they grow up, they would ask their doctor. So if they have a sensory need, like a whittle seat, if they need braces because they have pain in their legs or their arms or their back, whatever, talking to their doctor, advocacy, having an advocacy for that. Moving into my just college, I know that was touched on as well. Well, before that, I also did have DVR services. I forgot to put that in my initial notes. They helped with my college. And again, I went to UW-Whitewater for special education. I wanted to do that since age 7. But the DVR helped pay for certain services on campus. I had the opportunity or the option to take the transportation on campus if I needed it. Though Whitewater is a smaller campus, they do offer Warhawks on Wheels, which is a van that is wheelchair accessible that will transport you to different classes. They also paid for a tutoring service that I had one-on-one tutoring for any class that I wanted. It was just the tutoring service was completely covered. It was up to me of how many sessions I wanted, what class I needed it for, so that was amazing as well. The CSD, or Center for Students with Disabilities service at Whitewater, also allowed me to have modifications in the dorms and in classrooms. So instead of an IEP or 504, they called it a visa. I can't quite remember what that stood for right now, but it was basically an individualized learning plan, which the professors, I had to give them a copy of. It was my responsibility to talk with my special ed advisor at the center and say, I need a note taker. I need to be able to sit up in the front of the classroom. If I need to be in a downstairs, if I'm in a wheelchair, or if any student is in a wheelchair, they have to move the class for them. So you first tell this advocacy service what you need, and they make sure it happens. So that takes you as an adult knowing what you need. I knew for myself, after the first few weeks of school, that having my bed lofted was not a good idea. I struggled to constantly climb up it. So I emailed the service and I said, hey, I need my bed taken down. I have this condition, neurofibromatosis. I explained it's strenuous on my joints, and I need a lower level bed. I also had the rights to take elevators. I made sure that the buildings had elevators that my classes were in, that the dorm hall that I resided in had an elevator, and that the director knew of the dorm hall or of the education hall that I possibly would need to take the elevator, so I would get an email if it was going to be out of service or going under maintenance, so I could plan ahead of time. Also with the CSD, I have a wheat allergy as well. So communicating that with them and with people around me, what my exact needs were, is vital in education. Letting them know what you need. You know yourself best. You know your needs best, how you learn best. So talking to your college professor, your advisors, the disability coordinator on what you need. All right. For transitioning to my health care now. So really knowing your body. Know how your NF presents, how NF presents in general. I know the internet can be a scary place. So talking to your doctor, your specialist about what you can expect, though they may not be able to exactly track your NF and how it will turn out, you'll be able to know that what symptoms you're experiencing are related to your NF. And let's see, knowing how to schedule your appointments, knowing who to go to. Again, if they mention a specialist, seeing if you can get a referral, knowing who to call, when to call them. When you do call, let them know the best times to contact you, the best way to contact you, that it's okay to leave a message. That way, you're not just sending a message or just waiting for them to call you. I'm one of the people that I'll just keep calling the doctor's office until I get a response. So they might not always like that, but you're getting your answer, you're getting things clarified. When I am making appointments, I usually make sure I call, if it's a very far in advance, I call again just to see if they have anything that has opened up earlier, if anything's been canceled, or if I can get any sooner. Really explaining to the receptionist who's taking my call what the problem is, leaving a message for my doctor if it's a more urgent need and I'm not able to wait several weeks for an appointment. Don't be embarrassed to tell the receptionist what your problem is. Be not completely explicit in what you need, but let them know this is a serious problem. I need to leave a message for my doctor. That way you can get in sooner and get your questions answered faster. When making your appointment, know where to go. I usually take a trip there the first few days prior so I know where I'm supposed to be. That way I'm not showing up late, showing up at the wrong place. I'm on time, I'm prepared. Before I go to appointments, in the days before, weeks before, I draw out a little picture of a body and I start at the head. What questions do I have about the head? If none, I move down. That way I have everything covered when I go into my appointment. I'm prepared, not jumping around. My doctor knows exactly what my concerns are. They're able to take the piece of paper, answer all my questions. I won't forget if I want to tell them something, as well as really explaining what your symptoms are. As kids, our parents will usually share, oh, they're complaining of headaches, they're complaining of leg pain, they're complaining of fill in the blank, they're having this symptom. But as an adult, really sharing with your doctor, it's everyday constant, or it's only in the daytime, this is what it feels like, this is the frequency of it. That way they're able to narrow in more on what the problem is, as you know your body best, as you are yourself. So no one else can really speak for how you are feeling. You're able to explain to your doctors and the professionals what you need, and also telling them what you expect. So when you go to your office, say, hey, I'm expecting this to come out. I want you to help me with leg pain. I want you to help me figure out what's wrong. I'm hoping to get, and then tell them what you want. That way they're not just trying to guess. Really speak up for yourself. Speak up and speak out. Also taking notes at your doctor's appointments, keeping any medical records. If I get an MRI or anything, I ask the people at the MRI location for a copy before I leave. I've yet to have a problem. They just have me sign a paper, wait a few minutes for the disc, and then I can take it with me. Though my doctors will have it on their charting system, it's good to have a copy for yourself just in case you go to someone outside the charting system. Not that you don't like the doctor, don't trust the doctor, which if you don't, that's fine. Finding one who fits your needs, who fits what you need. Sometimes I'll go on the internet and I'll type in like orthodontist, neurofibromatosis. Someone who I can find that specializes in that field, also talking with your doctor, seeing who they know that specializes in it, because having NF a lot can be different about your body and you might need a special sort of doctor. And also knowing, again, back to knowing what you need, knowing not to be embarrassed if you need an electric cart at Walmart, if you need to wear your orthopedic braces. I do have ones for both my legs. I choose when I want to wear them. I used to want to wear them or think that I had to wear them all the time, even if I didn't have pain. But as I became an adult, I realized I don't have to wear them. They do help me at times. So knowing as an adult, do I always have to do this? Knowing what medications you take, knowing your doctor must have thought it was in your best interest to take it, knowing the side effects as well, talking to your doctor if something's wrong, but really communicating with your doctor, not just waiting for them to say to you, is everything okay? Because most doctors aren't going to coddle you, the real world not going to comfort you. You need to speak up for yourself, tell them what the problem is, tell them what you're experiencing. And just a little more into treatment, really asking them to clarify what is it that you're treating, what is it that I can expect from you, what can I expect at this upcoming appointment? Do I have to bring anything? Do I have to do anything special? It's really planning and preparing ahead for yourself. I know for me, transitioning, I started at the clinic here at Children's, and then I moved to Freighter Clinic. So really saying to them, so when I was at Children's, I remember getting my head measured and having to bend over. They checked my spine. When I moved to Freighter, they didn't. So I asked them about the differences that I could expect from moving into my child care into my adult care. That way I don't think they're just passing me over and saying, oh, we don't have to do that anymore. If you want something done, ask your doctor about it. There's nothing wrong with asking questions. And just ending tips, practice now. So if you have children who are not yet ready to make such big medical decisions, making minor decisions such as what you want to wear, what you want to eat, if just saying, do you need, and then fill in the blank for them. And let them really say yes or no, not just giving them answers. It's very important that I've learned as a teacher as well not to just give kids answers, not to just help them immediately, not saying you have to let them struggle, but let them make their own decisions and see if there's either a repercussion or, oh, maybe I should have done this instead. As well as planning ahead, knowing where your appointment is, knowing if your prescription's running out of refills, you're running out of meds, you need to call it in because your parents aren't going to do that for you. Your doctor's office or your pharmacist, unless you have an automatic refill, isn't just going to fill it for you. Do your research, know what NF is, talk to your doctor. As I said, the internet can be a scary place, especially if you just do a basic Google search. Though there are many sites that are reliable, other sites can lead you into some scary thoughts. And again, making notes so you're prepared when you go to the doctor's office. So you know what you want to talk about so you don't miss anything the moment you get out. I know I've had that moment plenty of times of, oh, I forgot to mention this. So making sure I have that list of everything that I want to talk about so I am prepared and ready for when it comes to the appointment. And that is all I have. Did anyone have any questions?
Good morning. My name's Heather. I am one of 3 of the nurse practitioners here at the NF Genetics Clinic. Today I will be introducing Dr. Klein-Tassman. Dr. Bonnie Klein-Tassman is a professor in the Department of Psychology at the University of Milwaukee and is a director of the Child Neurodevelopment Research Lab. She completed her PhD in psychology at Emory University with specializations in clinical psychology and cognitive and development. She completed an internship in child clinical psychology as well as postdoctoral training in pediatric neuropsychology at the University of Chicago, Department of Psychiatry. As director of the UWM Neurodevelopment Research Lab, her research focuses on the cognitive, emotional, and behavioral characteristics of children with neurodevelopmental disorders. She has published research about the cognitive and behavioral characteristics of children with NF1. Current research related to NF1 includes a study following children with NF1 from preschool to school-aged years to better understand their attention, psychosocial, and academic functioning and development. And also a study to identify which measures are best to assess attention in children with NF1. So welcome, Dr. Bonnie Klein-Tassman.
So I've got handouts here if anybody wants them of the slides, and I'll pull them up quick.
All right. It's good to see all of you today. So first, you've heard an introduction, and thank you very much for that. I want to talk a little bit about what it is that we do in our lab so that you have some background about where it is I'm coming from. As has been mentioned, we do research about the development of children with neurofibromatosis. We've been doing that since about 2008 in collaboration with the Children's Hospital of Wisconsin and NF Clinic. And this work has been funded largely by NF Midwest. Also it got started because of a University of Wisconsin-Milwaukee Research Growth Initiative grant at the beginning. And we've also had some funds from NF Northeast and NF Mid-Atlantic and from the University of Chicago, CTSA, which is a kind of collective for grant funding. And we're interested in understanding lots of different aspects of functioning. We believe that each child with neurofibromatosis has lots of different pieces of what makes them who they are, some of which have a lot to do with neurofibromatosis and some of which really have nothing to do with neurofibromatosis and are just who they are as a person. And we try to see if we can do a nice comprehensive look during most of our research studies. Right now, we're doing 2 things. One is looking at data that we've collected already. We have seen a number of kids in the preschool years when they were 3, 4, 5, and 6, and then again when they were between 9 and 13. And we think that that has the potential to really provide a lot of information that may not be so relevant to you in this room as you're older than that, but newly diagnosed individuals with neurofibromatosis having a sense of what does the pattern of development look like over time. And then, as we mentioned, the other thing we're doing is looking at measures of attention, and that's in young kids because there's very little literature on how it is that you can best assess attention in really young kids. So I have some flyers for the attention study if anybody's interested, but I wanted to give you a sense of what's going on right now in the lab. So what I'm going to do now is talk with you a little bit about current literature about psychosocial functioning in neurofibromatosis, and then some practical steps to help individuals with neurofibromatosis and their families related to psychosocial functioning. So first, I want to talk about what are the common cognitive and psychosocial difficulties that we see in neurofibromatosis. And so first, we see a slightly lowering of intellectual functioning overall in comparison to siblings. It's not a very marked lowering. We don't see a lot more intellectual disability, for example, but it's kind of just mild. Okay? Increased rate of language problems and visual spatial problems and visual motor difficulties. In the domain of psychosocial functioning, which is the one I'm going to concentrate on most today, we see that having neurofibromatosis increases the likelihood that you may have attention problems or what we call executive functioning problems, which is difficulties organizing and motivating to accomplish tasks of daily life. There's an increased rate of social problems and an increased rate of anxiety and depression problems. And then there are also learning problems associated with neurofibromatosis. But what I really want to emphasize here is that there's a really large amount of variability. So when I talked before about how we really try to understand each child and where it is that they're at, this is because having neurofibromatosis doesn't tell us that the child is going to have attention problems. It doesn't tell us that you're going to have learning problems. That we have to figure out what is your reality. And there are a lot of people with neurofibromatosis who don't have these difficulties. And then there are also quite a few people who do have these difficulties. And so we want to be able to think about what is the challenge that you're experiencing. And the other thing I want to keep in mind is the recommendations I'm going to have address certain areas. The reason that you have the difficulties in those areas might be related to neurofibromatosis, but might not be. It might be some other factor that contributed to these difficulties. So for those of you who don't have neurofibromatosis, you might still find a lot of what I'm going to talk about useful for you. Okay. So first, anxiety. How many of you sometimes experience anxiety? Okay, should be every hand up here, okay? Anxiety is what keeps us alive in many ways. Anxiety is what makes us scan the world and figure out what's safe and what's not safe and make decisions accordingly. And when anxiety is a problem is when it gets in the way, when there's a false alarm, or when it stops us from doing the things we'd like to do or that we need to do. And that's when anxiety gets in the way. And anxiety can be about lots and lots of different things: separation from parents, world events, specific fears, social interactions and relationships, lots and lots and lots of topics we can experience anxiety. And in our research, what we're seeing is that if we ask parents about anxiety experiences in young kids with neurofibromatosis, we're not seeing a lot of them when they're really young. There's some evidence that anxiety is increasing some in those school-age years, but it's still not at a level where there are a lot of people with neurofibromatosis experiencing anxiety that would fall in the clinical range. And the adult literature suggests that the anxiety rates are a little bit higher in adults. And so this is something that we're going to want to see over time, is what happens with anxiety over time. But really emphasizing that anxiety is also just something that lots and lots of people experience out there in the world. So there are three parts when psychologists think of anxiety as having three parts. They have what you do when you're anxious. So you might stay away from something, you might cry, you might pick at your nails, you might say, I'm nervous. Those are the things you do when you're anxious. There's also one very large component of anxiety is what your body does when you're feeling anxious. So you might tense up. For me, I get kind of butterflies in my stomach. Every time before a talk like this, I have to go to the bathroom. Those are physiological manifestations of anxiety, and all of us have them, and they give us a clue that we're experiencing anxiety. And then the other is thoughts. Anxiety is characterized by a lot of negative thoughts and negative expectations. And when we're looking at and coping with anxiety, we can choose to do things that fall along any of these areas. Okay? So in terms of physiology, we can breathe, right? And take a nice deep breath in a moment. We can figure out where we hold the anxiety in our bodies and find ways of relaxing those parts of our bodies using either something called using muscle relaxation exercises or using even simpler techniques. So I'm going to have you try one for a second, okay? So I want you to take your whole body in your seat and pretend that you are a robot. So tense up every part of your body, just tense up everything. And then I want you to be a rag doll in your seat. Okay? And as you're a rag doll in your seat, you can feel the tension release from those muscles that were tensed up. Okay? And robot ragdoll is a really, really powerful approach because you can use it anywhere. So, I would challenge you to try to get me to notice if you're doing ragdoll. You don't notice it. You're sitting anywhere. You can do that anytime you want. And that can be a really nice way of kind of centering yourself if you're noticing that you're anxious. So that's that physiological. In terms of behavior, simply noticing when am I feeling this emotion and what am I doing is a step towards doing something different. Okay? So thinking about what do I do when I'm anxious and do I want to make a choice to do something different when I'm anxious? Okay? And then there are also ways of addressing thoughts. This can be easier for some people than others. There are some people who find thinking about their own thinking to be a really hard thing to do. Other people find it easier to notice how they're thinking. And there are certain kinds of alarm words in thoughts that tell us that we're feeling anxious or depressed. And so those kinds of alarm words include things like always. So if I find myself saying, ugh, she always treats me like that, okay? That's an alarm word, and it tells me that I'm probably not thinking in a balanced way because probably if I really think about it, maybe this person often treats me that way, but they don't always treat me that way. And it feels very different when you say to yourself that something happens always or something never happens than it does if you can find a way of taking a more nuanced view of what it is that's going on. So here are some kinds of coping self-statements. So sometimes it's hard for people to notice their anxiety and their anxious thoughts, but these are some thoughts that, regardless of whether you're noticing your anxiety or your anxious thoughts, if you notice your anxiety, regardless of whether you notice your thoughts, you can use these kinds of things. So one of the things to keep in mind is that you don't need to always let anxiety get in the way. So you can decide that you're going to feel anxious and you're still going to do it. So for example, if you're going to a party and you're kind of nervous about interacting with other people, you have choices. You can decide, I'm not going to go to the party and not interact at all. Or you can decide, I'm going to go to the party and I'm going to be anxious, and it's going to suck to be anxious, but with practice, it's going to get easier to go to the party. And so I'm going to go anyway. And maybe at first I'm only going to go for half an hour, and I'm going to arrange for someone to pick me up after half an hour. And maybe my goal the next time will be to go for 45 minutes. Maybe my goal the first time will be to go to the party but not talk to anybody. Maybe my goal the second time will be to talk to one person who I already know. Maybe my goal the third time will be to talk to somebody I don't know. So gradually making those kinds of goals. In general, thoughts like it's okay to be nervous, it's okay to make mistakes, it's okay to ask silly questions. And the other thing that we know about anxiety is that feeling of anxiety, that really intense feeling of anxiety, your body can't stay in that feeling very long. Physiologically, it tires itself out. And so one of the things that we know is that if you're feeling that kind of intense feeling of anxiety, if you wait, it will dissipate. If you wait, you won't feel as anxious. You might not feel 100%, but you're not going to feel that intense feeling of anxiety for a really, really long time. Okay? It will go away. And sometimes saying that to yourself in the midst of that feeling of anxiety can be really helpful. So, as I've mentioned, some of the things you can do to cope with anxiety if you experience it, and if it gets in the way for you, and if it stops you from doing the things you'd like to do, is notice it and name it, calm your nervous system, avoid avoidance, okay? So the thing that we usually do when we're anxious is stay away. That's our natural inclination. The problem with that is then we never learn that we can actually cope. We can, as long as we take it slow, okay? So staying away from things that make us anxious actually strengthens the anxiety, increases the anxiety. So in the short term, we feel better, but in the long term, we're stopping ourselves from doing the things we'd like to do. Keep practicing. Find ways of doing it anyway. And when I say do it anyway, I don't mean do the whole thing of whatever it is you're afraid of. Take little steps towards it. And then the other thing is give yourself credit for attempts to cope and attempts to move towards the anxiety, even if they're tiny. Okay, so notice them and give yourself credit for them. One of my graduate school advisors has a book that I really, really love called You and Your Anxious Child, Free Your Child from Fears and Worries and Create a Joyful Family Life. And I strongly recommend that book to anybody who is experiencing anxiety. It has some really, really nice tips in it. So depression. How many of you sometimes feel down? Again, sadness is a part of life, right? What we do know is that adults with neurofibromatosis appear to be at increased risk for depression. Now, depression is a very, very common occurrence. I think statistics are about 1 in 5 individuals experience depression at some point in their lives. That's a lot of people, right? So depression is a very common thing. It seems like it is more common in adults with neurofibromatosis. I will say that in our work with kids, we're not seeing a lot of it yet, but I also think it's really hard to measure in kids, okay? And also, depression in kids can look different. It can look more like irritability and not so much like sadness, okay? So we don't yet know when those kinds of depression symptoms are most likely to emerge, and I think that we need more research on that. But what I want to talk about is that depression itself also has 2 pieces to it, okay? It has the thoughts and feelings that are associated with depression, and it has the behavior that's associated with depression. Okay? And in terms of behavior, what happens when people are depressed is that they're less interested in things and they engage in the world less. They do fewer things. They spend more time by themselves. They don't eat as much. Their sleep is disrupted. They're not concentrating so well. All of those are behaviors associated with depression. And then the thoughts and feelings that go along with that are feelings of sadness and irritability and worthlessness, and even thoughts of death. And that is part of what makes up depression, are those pieces, those thoughts and feelings and those behaviors. And those are all part of depressed mood. So what can you do about these kinds of things? So I talked before about the kinds of self-statements you can make to yourself if you're feeling anxious. There's similar kinds of things related to feeling depressed. So noticing that all or nothing thinking, and realizing that it's probably not all or nothing. Noticing catastrophizing, when you're expecting bad things to happen and you're pretty sure they're going to happen, are you right about that certainty? What evidence do you have that that's likely to happen? What evidence do you have that maybe sometimes it doesn't go that way? And thinking through those things can help, okay? A very big piece of what has been demonstrated in the literature to help with depressed mood is what's called behavioral activation. And this is an incredibly powerful tool. So as I mentioned before, when people are feeling depressed, they're interacting less with the world. And what happens is that means that they also get fewer of the goodies that we get from interacting with the world. So if you're not eating so well, then you're not tasting things you love. If you are not interacting with people, then you're not getting a chance for other people to talk with you about the things that might actually be going well in your life. If you're not exercising, then you're not getting a chance to get those physiological pieces that really contribute to our well-being, okay? And so what studies have found is that deliberately increasing contact with things that are called reinforcers, with things that maybe right now don't feel like they're all that helpful, but you remember that when you were feeling better, those things felt good. Doing those things anyway and scheduling them and making yourself do them can help break that depressive cycle. Okay, and that's what's known as behavioral activation. And at first, you have to stick with it for a little bit. At first, it might not feel like it's accomplishing what you'd like it to accomplish. But with a little bit of practice, you'll start what they say contacting those reinforcers. You'll start having more stimulation in your life, more interaction in your life, and you will feel better, is what the literature says, if you engage in these kind of behavioral activation. And the key is taking those steps and figuring out how to go about doing that. All right. So another area that we see some vulnerability for people with neurofibromatosis is in social functioning. So there are a number of studies that indicate that individuals with neurofibromatosis as a group experience more social challenges than their unaffected peers. And this has been found both with children and with adults, that there's an increased rate of social difficulties. And again, same disclaimer, that doesn't mean that everybody with neurofibromatosis is going to have social difficulties, but there is an increased rate of those social difficulties. So what can you do to improve social functioning? One thing that I often recommend to families is to watch teen television together. Okay? So how many of you have watched teen television with your kids? What do you see? What happens in these teen television shows? Anyone? What happens in every episode? Conflict, right? Misunderstandings. One person meant to say this, but they really said that. So-and-so is speaking to so-and-so behind their back and not communicating directly, and a whole kind of set of challenges emerges from that, right? There's a reason that our teen shows have all these conflicts in them. It's because part of teen life is figuring out conflict and navigating conflict. And watching these shows together can really give you an opportunity to be talking about, okay, so what do you think that character was thinking and feeling when this happened? What do you think they did this? What were some other choices about what it is they could have done? And it allows for problem solving of situations. And the other thing is that if you watch enough of them, there are lots and lots and lots of different challenges that emerge in these teenage and young adult years that come out, and chances are you're going to happen upon something that maybe your child didn't talk to you about, that they're now seeing and saying, oh, well, that happened in that show. You know what? That actually happened to me. And this is what happened, and this is how I coped with it. So watching teen television together and talking about what happens. The other is I encourage you, the adults in the room, the parents in the room, to talk about your thoughts and feelings in your friendships. So to talk about the challenges that you have in your own interactions with people, because everybody has challenges. And to talk about how you navigate those challenges. What do you say to yourself, or what do you do to get through interactions that might be more challenging with other people? And also, what do you do to keep yourself socially active? How do you do that? What do you choose to do that gets you in contact with other people and that has you building friendships? How do you do that? And then related to that, you want to be deliberate about seeking out opportunities for social connection. So you want to think about when do I have opportunities to connect with other people? And if I don't have any opportunities to connect with other people, what can I do to create those opportunities? And can I find a group of individuals with similar interests to mine to have more interaction with and to build relationships with? So social connection works best when you have some common interests. So you want to figure out, what are my values? What do I like to do? And how can I try to do those things together with other people some? Another is get involved even if it makes you nervous. Practice will make the nervousness lessen. And one of the things that's often recommended for when families are seeing that kids are kind of preferring to do things on their own and preferring not to engage in social interaction, to present the kind of social interaction scheduling, the extracurricular scheduling, not as an option of, do you want to do something? But we're going to pick one thing to do. Let's make a list of the possibilities, and which one do you want? Setting the stage that, part of living life is keeping busy and having leisure activities. And so we want to practice that when we're young. So not a question of whether to do a social activity, but which social activity. Okay. Another thing I wanted to touch on very, very briefly has to do with bullying. Okay. So there is a really great site that talks about things that kids can do if they're experiencing bullying. It's called stopbullying.gov. And it's an excellent, excellent site, stopbullying.gov. But I think the bottom line is that if you're being bullied, it's not really all your problem to solve. The research on bullying makes it very, very clear that an individual who is being bullied can't be the source of the solution for that bullying in its entirety. What needs to happen is that the system in which that bullying is happening needs to be made aware of that bullying and needs to come up with systematic, group-based approaches to countering that bullying. So what does that mean? It means that the one responsibility that the person who's being bullied has is to tell people. That's the one responsibility. And you shouldn't expect that you're going to be able to solve the problem all on your own. Okay? Yes, there are things you can do. And if you look at stopbullying.gov, it'll talk to you about those. So walking away is incredibly powerful. Okay? Having other friends so that you have a little bit of a buffer is also incredibly powerful. But fundamentally, this is a system problem, and the system needs to change. And so your responsibility is to let that system know it needs to change. And so it means you have to talk about it. And I know that can be really, really tough. So overall, what are the things that you can do to keep yourself healthy, to improve your well-being, to make it less likely that you're going to experience anxiety or depression? And the answers are all in your overall health. Okay? So the kinds of things that you can do to make it less likely that you're going to experience depression, less likely you're going to experience anxiety, is exercise, sleep, eat well, and interact with people. Social support and social interaction has really incredibly robust effects on health and well-being. And so these are the things that you can do that will help boost your overall well-being. Any questions? Anything, really. It doesn't have to be directly related to what it is that I was talking about. So I've solved all your problems? Yes?
We partook in the study at the university, and both my boys went. Andrew has an older brother, and we found it incredibly helpful and very insightful, and I would suggest that if you have someone of that age group, to participate in that, because you will learn a lot.
Yeah. As I was driving here today, I was thinking, that we saw kids when they were really young, and then we did a follow-up between 9 and 13. And right now, we don't have a plan for a next follow-up, but I don't know. I think it's a missed opportunity because we've got 27 kids who we saw 2 or 3 times when they were 3 to 6 years old, who we saw again at 9 to 13. And wouldn't it be really great to be able to see what happens over time? and what things are looking like in the adolescent phase, which involves so much challenge. So I'm going to be thinking about that, whether I can muster some resources to do another round. And thank you very much. I'm glad you found it helpful. All right, thanks.
I have the pleasure of introducing Dr. Amy Heffelfinger. She's a clinical psychologist whose specialty is pediatric neuropsychology. She trained at Washington University for graduate school and fellowship training. She joined the faculty at MCW in 2000 and is now the head of the pediatric neuropsychology section, the director of training for postdoctoral training in neuropsychology, and was recently promoted to professor. Congratulations.
Thank you.
Dr. Heffelfinger specializes in the evaluation and treatment of preschool and school-age children with neurological, behavioral, and developmental disorders in the neuropsychology clinic. She especially loves to work with children from a young age and help transition into adolescence and adult living. Dr. Heffelfinger's current research involves the study of early development of neuropsychological function with a focus on attention and executive functioning. Her work also investigates cognitive outcomes of adolescents with spina bifida, brain tumors, and genetic disorders. She presents her research at national conventions and publishes in peer-reviewed journals. Please help me in welcoming Dr. Heffelfinger.
Good morning, everyone. I see a few familiar faces and then some that are not. So if afterwards I don't get a chance to talk with you, feel free to email me with any other questions personal about your families, or if I've seen your kids, or if not, so that I can help out with you. I'm going to start today by just talking through what neuropsychology is and why it is important across the lifespan with neurofibromatosis type 1, but especially around the adolescent time. And first I'm going to see, okay, good. I hadn't tried to see how to make the slides move, but so I'm going to go over what we do, how we do it. I'm going to focus on learning problems, attention problems, executive functioning problems. Really want to kind of talk through why it's important in the teenage years and the young adult years to use us as best as you can to optimize your outcomes, particularly around transitioning into college and adult jobs and living. And then we'll leave a few minutes for questions. I also wanted to take a moment to introduce to you Dr. Brian Shields was a fellow of ours, graduated last week from our 2-year postdoctoral fellowship program. He is going to help me talk through some of the pieces around attention, executive functioning, and ADHD. Okay, so what is neuropsychology? Bottom line, what we do is we study how the systems of the brain affect cognitive functioning. So we look at the study of structure and function in the brain. And what that means is we assess cognitive and intellectual functioning. We look at emotional, behavioral, social functioning. I'm not going to talk much about that because Dr. Klein-Tasman just did, and her and I work together on all of these things. So she does what I do what she does, and we share patients. And then really what we try to focus on are what are a child's strengths and weaknesses. And the reason we do that is because it's important for any of us to identify what are our areas of weakness, but more important to understand what are our areas of strength and how do you use those strengths to be able to counteract or to help you accommodate for your areas of weakness. And then we integrate all of this with medical and neurological history. So this is just a schematic, very old school schematic of what we assess, because people often will come in thinking that we're going to assess a lot around behavior or around social functioning, emotional functioning, and we do touch on those because obviously everybody is one person. You need to understand the whole person, not just pieces, but these are the pieces that we are assessing. We assess using what are called standardized measures. So instead of just watching and saying someone's doing really well in this class in school or someone's doing having these kinds of problems, we do cognitive direct one-on-one testing that allows us to see, compared to another child this age, how is the child doing, to understand is it actually a true cognitive weakness or strength, or is it not? And that's really important because our own self-perception and also our perception of others around these things are not usually accurate. So the most common concern for parents of young children who have neurofibromatosis type 1 is their cognitive development. So outside of having a lot of medical complications, this is the first piece that we try to help address. And most studies do indicate that people who have neurofibromatosis type 1 have slightly lower abilities than their peers, than their siblings, and then normative controls. Now, there are a lot of factors that affect this, but I think it's really important for children to understand that if they think that they're having more problems learning than their peers, they probably are. And that's an important thing to listen to, because oftentimes when we're parenting our children or we're working with our students, we're telling them, you can do everything that your peers can just as well if you just worked a little harder. And while we want everybody to be able to do that, I think it's really important for every individual to understand if they're having difficulties, then maybe you are, and maybe we can get help so that it becomes a little easier for you. Also, if you guys have any questions and want to interrupt me, it's a small group, go ahead, just raise your hand and I'd love to answer questions as we go. So in addition to just general difficulties with learning, oh, and one more thing on that. When I say mild, lower abilities, I'm talking mildly lower. Most individuals who have neurofibromatosis type 1 do not have an intellectual disability, which means that they are going to develop into being able to work independently, live independently, and function independently. Not all, because there's a lot of factors that go into those decisions, just like across the population and across all disease states. But just because I say it's a little bit more difficult does not mean that it's impossible or that the learning problems are completely debilitating to one's development. Within the different areas of functioning that we look at, there are a lot of different pieces, and I'm sure that in listening today and in living your lives, you understand that every child, every individual who has neurofibromatosis type 1 has a different set of problems. The disease results in that. So unlike some disabilities where you could say almost everybody has this problem with their learning or almost everybody has this problem, you can't really do that with neurofibromatosis type 1, and that's because of the variability within the disease state. So research shows that there are difficulties in almost every area of neuropsychological functioning, from perception, particularly around visual perception, integration of vision with motor, so for things like writing, gross motor skills, so clumsiness, learning to ride a bike, learning to do complex motor tasks can be very difficult. But also you'll have some individuals who have more difficulty developing language and then communicating throughout their lives because their language development was affected. Lots and lots of individuals have problems with attention and executive functioning. Dr. Shields is going to explain what that means, but one of the weirdest things and maybe coolest things that I've found in what we do is that in every single childhood onset disease state that we have, you see problems with attention. And the reason for that is because the attention systems of the brain develop very early and they're widespread throughout the brain, so that anything that is going to affect the child's development is going to affect attention too. So it's across almost anything that affects children, as well as kids who don't have chronic medical or neurological conditions. Attention is very easily disrupted in the brain's development. And then some individuals do have difficulties with memory and learning. Rarely, when we see a child or an adolescent who has neurofibromatosis type 1, do we see that they have problems in all of these areas. Most of the time, they're functioning wonderfully in most of them, but then one or two may be a little bit lower, with the most common being the attention and the visual motor integration. So difficulty, when kids say they're having difficulty copying off the board or handwriting, they probably are. Okay, Dr. Shields.
So like Dr. Heffelfinger was just mentioning, attention problems tend to be one of the primary concerns that parents, even teenagers, will report when they come to see us, and it's one of the big things that they ask us to investigate and look at with our testing and give some recommendations. So what we often see is that parents, their children will come in and they'll say that their child is easily distractible, they can't stay focused for long periods of time, they're very forgetful. You often have to say things 3, 4, 5 times, repeat yourself a lot of times. They miss instructions in the classroom, forget their homework, things like that. They also might avoid tasks that might seem on the surface to be relatively straightforward and easy to complete, but just it requires a little bit of extra mental energy that can be harder for kids to kind of put into completing them. And they make a lot of careless mistakes on homework, on tests, on completing things around the house. So it can look very different depending on the child, but it all sort of falls under sort of this sort of larger difficulties with attention. But we also see difficulties in the area of executive functioning, which I'm not sure how many people are familiar with kind of this broader term, but really it's kind of an umbrella term that we use to describe different cognitive skills that we are able to use to kind of put forward to solving problems and working towards meeting a goal, usually something in the future. So when your child is given a book report assignment in school or a science project in school, it's all of those steps and all of those skills that they need to work towards that longer term goal. So what research has started to show is that there are kind of 3 core executive functioning skills. Inhibition, both behaviorally, being able to kind of inhibit those behavioral responses, but also mentally and cognitively, being able to sit and, while you're working on your math homework, all of a sudden you think, oh, I wonder what the score of the Brewers game is right now, is being able to keep that in the back of your mind and keep your focus on what you're doing in that moment and not pulling up ESPN on your phone or on the computer to check the score, and then all of a sudden you're, an hour later and you still haven't completed your work. Working memory, which is kind of that first step, what you do with information that is first presented to you, and you kind of have to hold it there, use it, organize it in some way. And then cognitive flexibility, or kind of other terms for that are sort of mental set shifting, or kind of being flexible and remembering different rules and applying different rules as you're going through and doing different tasks. And then from that comes the reasoning, the problem solving, the planning, some of those, sort of larger skills that help us reach, those goals. So what we see in kids with neurofibromatosis is up to 50% of kids have difficulties with attention or executive functioning that are severe enough to meet criteria for a diagnosis of ADHD. And that is compared to about 5% of the general population of kids. So, certainly, like Dr. Heffelfinger was saying, if you're seeing difficulties, or your children are saying that they're having difficulties in some of these areas, it's probably true for them. And the challenging part for that, especially in the teenage years, is that I think for a lot of people, when we think of ADHD, we think of things like this. Right? But as kids get older, we start to see less of these hyperactive behaviors, and we start to see difficulties that in reality look more like this. Being in the classroom, but kind of looking like you're paying attention, but you're really kind of zoning out, or you're not really there. You're avoiding tasks, or you're getting off track very easily. Your children might seem very overwhelmed and have difficulty sort of getting started or seeing a task through, because there's just so much information there that you kind of don't know how to start. It almost feels like you're kind of spinning your wheels, but you're not making any kind of movement towards meeting that goal, which can oftentimes result in a lot of late nights and a lot of pushing up to the deadlines or missing deadlines for things in school. So it's important to understand that these difficulties aren't, again, just related to a child not working hard enough or not putting in enough effort. These might be real difficulties that a more comprehensive evaluation or testing that might be done with a neuropsychologist or somebody can kind of start to go in and identify some of these specific skills and then give some recommendations. Because what we've also seen in the literature is that the same types of interventions that work for patients who have ADHD who might not have neurofibromatosis or other medical conditions where we often see a higher rate of ADHD, those interventions, both from a behavioral perspective, medication perspective, supports in the classroom, work just as well. So that's sort of the benefit of being able to come in and sort of identify where some of these specific difficulties lie. So you wanna- okay.
So additionally to having difficulties with the focusing of attention, planning of time, managing of time, a lot of individuals also have learning problems that reach the level to call a learning disability. And 36 to 65% have a learning disability compared to 5 to 17%. Oftentimes it is in reading or spelling, particularly around the complexity of reading and spelling, so the comprehension, understanding, and what's needed to write. Like I talked about before, if a child's having problems with the act of writing or with getting their thoughts down on paper because of the visual motor problems, well, then they're often going to have a hard time with composition as well. Individuals who have NF1 often have problems with math. So learning the math facts can be an incredible challenge. Additionally, learning how to do the word problems can be a challenge as well. So nowadays, it's really hard to figure out whether or not someone has a learning disability from an academic perspective. And we have to work really, I shouldn't say it's really hard, it has changed, which for those of us who've been doing this for 20 years, it's hard for us to learn how to do something different. It might be easier for families now, but from the school perspective, to get a classification of a specific learning disability, a child has to first demonstrate that they are not learning in that area to the level of somebody else. Then they have to go through the next tier of intervention, which is group-based, and then the next tier, which is individual. And if you don't make progress in those areas, that's when they're going to call you having a specific learning disability from an educational standpoint. Often good to have us involved. So while you might hear that having an evaluation for a learning disability is really, like, it takes years to get one and you can't get in to see us, if you have a diagnosis of neurofibromatosis type 1, we're going to get you in and we're going to help take a look at this and we're going to help tell the school where your problems are and what you need, working with them within their structure, because there's a way we can bypass that process. You don't have to have a classification within the school district for specific learning disability if you have other health impaired, which is a classification you can get for having some kind of medical or neurological problem that's impacting your learning. So oftentimes partnering with us and partnering with the schools will get you the help you need in a less laborious way than if you only go through what the school district's process is. Also, most individuals don't have problems with both, with all reading, writing, and math, but some do. So I've mentioned a couple times the variability. From a neuropsychological perspective, I'd like you guys to understand what are the factors that, that increase one's risk to have more of these types of cognitive and learning problems. And the first thing that I don't even have on here is multi-generational disease. So individuals who have families who have neurofibromatosis going back a couple of generations often have more difficulties with learning. And that's for a whole lot of different reasons. And I say that just so that you understand kind of how to get help early for your children to help alleviate some of these problems, or at least reduce them if you can. Next, the amount of brain-based involvement from the disease. So some individuals have almost no disease burden in the brain, and some people have a lot of disease burden in the brain. We don't fully understand how the spots, in quotes, because we don't totally understand what they are in the brain, how they're interacting and, with development, but we do understand that the more that NF that the genetic expression is in the brain, the more difficulties one will have with learning and with attention problems, regardless of whether they have tumors in the brain or not. Of course, anyone who has seizures are always a challenge for learning. The reason being that a seizure will often interrupt the action that the brain is doing to learn and remember. So if somebody has seizures, doing everything possible to do medication management for that. Yes? So you detect them in an MRI, but what we've learned over time is that they often move and change. So there's not something you can do about those spots, and they alter and they adjust with development, but yes, that's how you see them. The balance of doing multiple MRIs, though, because there's not a treatment for them, then you have that risk of having multiple MRIs, which you only want when you need to. I think you're next.
As a child grows, the spots kind of disappear in the brain, is that correct?
So I guess I don't know for sure whether they disappear with age, but they change over time. I don't know, do they reduce?
Well, we don't have longitudinal data of children who've had spots and then track those over an extended period of time.
I think my daughter had spots younger, and she's had a lot of MRIs recently, and
So
they hadn't noticed any.
Anecdotally, they do tend to wax and wane. We tend to see them more in young children, and we see them less in adults.
Okay. All right.
Yes.
Just to clarify, are those the unidentified bright spots you're
talking
about? Okay.
Yeah, the UBOs. So I went with the word spot because it seems a little less frightening than unidentified bright spots. So you're actually identifying them, right? You see them, so they're those spots that show up brightly on the MRIs. Other questions about that? Okay. And so then the other aspects of the disease burden that are outside of the brain, well, the tumor here in this last one, those absolutely, if you have gliomas, optic gliomas, those are going to interrupt your development of your neural systems because it's affecting with your vision, and then also depending on where, like any other tumor process, if you have a tumor in the brain, where it is can interfere with the development of that area and can increase the risk of the learning problems. And the research does indicate that having a lot of medical burden outside of the brain is related to also having, or correlated to having, more problems with learning. Whether or not that's just because that demonstrates a heavier disease burden on the whole child, or whether it's because if you're experiencing a lot of pain, you're missing a lot of school, you're having to have a lot of procedures for your medical care, and just to maintain how you're doing every day. We know for anybody who experiences pain and experiences a lot of interventions, a lot of hospitalizations, you have more difficulties with the constant reintegration to school. Okay, so I think that you talked on some of this, Dr. Shields. I'll go through this again. With attention problems, with learning problems, we don't want those to go unidentified. And so for many of you, I know I saw you when you were much, much younger, maybe 3, 4, or 5, or you saw Dr. Klein-Tasman when you were younger. That's the best case scenario. So if you have a child, you really want to start to understand where are these areas of potential risk as young as the child can be, so that we can follow them. We may not be able to treat them, but we can help parents and teachers and individuals understand what they can do to help counteract it. So for example, oftentimes what we'll see is there's a child who really likes to talk, but doesn't like to do puzzles, doesn't like to build, doesn't like to move a lot. So they just kind of like to follow around their parents and talk. And they just keep talking, and they keep talking, and they keep talking. So often what that child is doing is they're developing their verbal systems of their brain, which is what their strengths might be, but they're not developing their eyes, how their eyes are coordinating with their hands for things like building, construction, crafts, and writing. And that process of developing your strengths and your weaknesses get set really early in life. So if we know it, we can say, okay, we're going to spend a couple minutes every hour when you're 3, 4, and 5 working on puzzles and crafts and those things, and playing independently and having some ability to kind of focus your own time to try to push up those areas of weakness, not bringing down the strengths, but just try to push those up. Once a child is developed, it's very hard to change that pattern. And we don't have great data to say, can you change the pattern? But I do have lots of anecdotal evidence that you can, in your individual child, help to improve some of these things. Once you're in that older school age time, so the 4th grade through 8th grade time, wonderful time to start to identify how to, I think this is going into, okay, sorry. I'm talking about a slide coming up. I'll save it till then. Okay, so when you're in that adolescent time, so the middle school time, what you're going to start to see is that your child or yourself may be having more problems in school than you were before, because the burden for organization, planning, independent work becomes so much higher at that point in time. And then once you get into high school, it's so common for me to have families coming in and saying, my child was doing really, really well in middle school, but now in high school, they want to see if they can be independent. And they want to see what they can do on their own, and they're failing. And everyone nowadays says we should let kids fail. And I'm going to talk more about that in a minute, but I don't think that that's true. I don't think that's true for any one individual ever in life, that failure fully is a good thing to help motivate success. So when to get an assessment, neuropsych assessment, repeat neuropsych assessment is useful only every couple of years. So we can't do much with how to help you because we don't do the therapy or the training, but we might help you get that. If you have not had a neuropsychological assessment in your current stage of life, that's always a good time to get another one. So if you had one when you were 7 and you're now 15, 16, and you haven't had one, it's probably a good time to get one. So what else affects development? I'll get back into the how to advocate for yourself in the teen years in a minute, but I do want to mention that your development, we talked about the medical pieces, development is very much impacted by how you're doing in your family in general and also socially. And so those are pieces that, while I'm not talking about them, to always remember that that's going to affect how you're developing cognitively as well. The success, the health of the individuals in your household and the health of the relationship of the individuals in your household at every part of your life, no matter what your age is, does impact how you are doing personally. And so that's really an important thing. Oftentimes when we're working with the really young kids and you see that the burden of the disease is really affecting the marriage, or if parents aren't taking care of themselves, they're putting all their energy into their kids, it's really important to make sure that families are getting that help because it does affect your child's cognitive development. Okay, so what do we do with our data? So once we talk with you about what your strengths and your weaknesses are, we'll often do some big kind of recommendations. We are going to refer you to other medical providers for areas of problems that you might need help with. So if you have a diagnosis of ADHD, medication for ADHD is effective in neurofibromatosis type 1, maybe not to the same level as it is for someone who has ADHD that's not related to neurofibromatosis type 1. So I think the data is that individuals respond maybe 50 to 60% of the time with NF type 1. So it's still worth a try, but if it doesn't work, don't take medication throughout your life just because someone told you you should. If it's not helping you, then you shouldn't take it. And then also we'll refer to mental health providers, therapists. We're going to help you get help with school. And so this is a piece where I think the involvement of teenagers in the process of the assessment and also in the process of their own care is really important. Schools no longer, I don't know if high schools ever were very involved in individual care, but it's very hard to get to have high school systems be able to manage the problems that you have in learning. So what we often need is that the child is capable of, the adolescent is capable of saying to a teacher, I need a little extra time with you, or I need more time on my test, or going into their guidance counselor and saying, this isn't working for me. Like, I'm not learning, I'm sitting in class and this teacher talks at a pace I can't possibly understand. If teenagers aren't telling the teachers that, the teachers can't do anything about it. Now, I was not really good at advocating for myself, so I totally understand when people can't do that. Tell your parent, talk to us, get that help, because those 4 years are so important and what happens after that. I had a patient last week where she was doing really well in one class, she was doing really well in a language, and everything else was really poor. And I was like, well, how come you're turning in your assignments in there? And she's like, because I know how to do it. And I was like, well, then you got to find out a way to do all the other classes too. And her teachers didn't know that she was having those problems, nor did her mom, so they couldn't get help. But then we can help with those things. But it really does require that the adolescent gets involved for that. Okay, so we've talked through that. The last thing I want to talk about is in that the older high school time. So if you have not had an evaluation for a long time, or if your patient hasn't had an evaluation for a long time, really important in that later high school time, because we can help with most of your accommodations that you're getting in school can transition into college. We can help with what those are exactly going to be to make sure that they are right for you at that point in time. For individuals who are not planning to go to college, we can help with things like, how do we get you into additional job training? How do we get you help in the home so you become independent in your own self-care and helping with others? How do we make sure that you don't become one of those individuals who is just staying in the house and not having a productive and life that they want to be having? And also we can help with the guardianship process. So if you do have a patient or you are an individual who is not going to be capable of having an independent life, meaning you can make all of your own decisions, you do your own reasoning, manage your own money, we will help figure that out and help with the guardianship papers. Okay, so we here are in, if you're under 18 or 18 or under, you're going to see us in the Children's Hospital Clinic. If you are over 18, you will see us in our Freighter Clinic. We have fellows that we have trained. We're blessed with having one of the better fellowships actually in the country, which has allowed us to have fellows pretty much across the state as well. So while you guys got to hear Dr. Klein-Tasman talk, we didn't train her. She was trained in University of Chicago, but and she's fantastic. You can see her, she does research paradigms, so you can't typically go there for a clinical evaluation. Same with Dr. Herman at UW-Madison. But we do have really good neuropsychologists in Green Bay, Marshfield Clinic, Appleton area, and pretty much anywhere else. So if coming here is burdensome, we can help you figure out how to get people to areas that have really good pediatric neuropsychologists. Questions? So I did not have, yes, go ahead.
I just have a comment.
Yeah.
I found as she got older, she had a 504, and she had several teachers that did not like to follow a 504.
Yes.
There's a lot of teachers who do not have patience for a child that has a disability. And so I had her take her 504 and keep it with her in her binder. And I said to her, if you have a question on what they're doing, if it's against your 504, you need to comment. You know, I have my 504 here, and it doesn't seem like you're following this. And I was telling someone else she had a provision in her 504 where she could use a calculator, and a teacher refused to let her use it. And she came home and told me, and one thing, it's very important that your children communicate with you as a parent.
Absolutely.
What's going on at school. Don't keep it a secret. Don't not say anything. Say something. And when she came home and said, I said that they didn't give me my calculator, and I asked for it, and he wouldn't give it to me. So I wrote a little note that said, obviously you're going against her 504 if you're reading this note. Do we need to talk? She immediately got her calculator. So having, as they get older, keeping a copy of whatever documentation they have for their modifications is very important, because they don't always remember. But if something's not right, they can look at it and say, hey, wait a minute, you're not doing something that you're supposed to be doing here. Now, the teacher may not like it, and that's when I would get involved. If it went further, I would let her handle a lot of it. But in college, she handled all of it. But in high school and middle school, if she couldn't handle it, they usually had a big cross held up when I walked in the building. Because they didn't want to see my face. So usually if she said something, it was handled. But it's very, very important that the child communicates with the parent. Very important.
Absolutely, and I love so much of what you said because it demonstrates the necessity for the scaffolding process of parents and doctors at this age, where it is our responsibility as the doctors, as the parents, as the adults, to make sure that the people in the school building know what kids need from a very young age on. It is our responsibility to make sure that our teens know how to interact with the professionals, because they're most likely not going to learn it on their own. There are the occasional individuals who have that individual tenacity, but most of the time they don't. And so you really have to do this, like, give this a try, make sure that when your teens are practicing it, they're successful, because you're only going to keep doing something if you have success in it. So you got to make sure that you then come in when they're not successful and say, okay, wait, you should be successful in this because it's the law. You know, these are legal requirements that our kids should have. And so we have to make sure to help people understand how to do that. Yeah.
I wrote her 504. I know my daughter, and I know what she needed academically. They didn't know her.
Well, typically we'll help, just so everyone else knows. You don't have to be able to do that as a parent. Right. But so that's a fantastic thing. And so you can do it, kids can do it. You can find out what they need. But that's having that 504 plan or having an IEP, depending on the level of need that your child has, is really important.
I mean, they had to okay it.
Yes, of course.
I went online and looked up different IEPs, different 504s, different things that people that had neurofibromatosis, and she's dyslexic, so and I combined all of it, and I wrote it and took it into the meeting, and they approved all of it.
You should become a neuropsych advocate, it seems. Go ahead.
I didn't have one.
Yeah.
Go ahead. My comment is that IEP, if your child is having one all through their early years of school, you have to make sure you're the advocate, like you said, and make sure it happens for them at high school too.
That's right. And sometimes you have patients and kids who are willing to do that advocacy. If you don't, then you've got to figure out what your child needs. Is it a different school? Is it a different type of a doctor? Because there are different, like sometimes that's where a psychologist or a counselor can get in when a parent can't. If you can't get through to your kid to help do that, someone else can help with that. Yes.
And just to add to the carrying on an IEP, because an IEP needs to be reviewed at least once every year legally. But since I'm a teacher, I actually have a meeting with a parent next week who has a question about their child's IEP, because the parent has every right to deny or to question what you've done. And if a parent does not agree or wants their child to have more, there's that additional system to go into mediation and due process and a whole bunch of other legal things that the parent will fight for their child's rights. So if they don't agree, it's not just, oh, well, the school said no, so
that's right.
That's it.
There is a way to process through that. Absolutely. Thank you. I think there was a question in the middle here.
I haven't got a but once
No? Okay.
So I'm just curious, from a standard of care perspective, we sort of try to big transitions. So we look at the 4 to 5 year age group for school starting. We look at the elementary, so then from elementary school to middle school and then middle school to high school. But I don't think I've ever recommended anybody having a school exit evaluation who has been through that process.
So you're right. So Dr. Basil is saying that usually the referral comes for us at those major transitions in school. And usually there is one last one, which we would recommend ourselves, but you want something to happen in that junior, depending on the student. So if they are college bound and needing to get accommodations for their tests for for taking college entry tests, we want to do it for sure by the beginning of their junior year. But for individuals, and then that will carry over to college, so that'll transition to college. But for individuals who are more likely going to do continued education through the school district till 21, or there might be issues of guardianship, that has to happen at 17 and a half. So but usually we will take care of telling people when to come back for that time. So, and we'll also see, so you said starting at that 4 to 5 time, we will also see 2 and 3-year-olds too. So if you have the patients into birth to 3 OTPT and they're really engaged and involved, they're doing that, then usually we can't help much more. But sometimes getting in that 2-3 time is useful for a first meet for me. So, all right. Well, thank you all. It was really wonderful to talk with you today. Thanks.
All right, I'm Victoria. I'm a genetic counselor here, and I'm the newest addition to the NF team at Children's. And today I have the pleasure of introducing Dr. Santos. So Dr. Santos graduated from medical school in Sao Paulo, Brazil. He completed neurology residency at Cleveland Clinic in Ohio. That was followed by a fellowship in epilepsy at Dartmouth in New Hampshire. And he completed an additional fellowship in neuro-oncology at MD Anderson Cancer Center in Houston, Texas. So in November 2017, he joined MCW, and he sees adult patients with NF at Frederick Clinic.
Thank you. Good morning, everybody. All right, so let me talk to you more about how we do this transition of care from this wonderful facility of Children's Hospital of Wisconsin to Frederick Hospital, more specifically the Cancer Center. So how care is done across the street. So we have this group of neuro-oncologists, neurologists, neurosurgeons, neuropsychologists, APPs, and nurses, and social workers, and case managers and counselors, all of them united to provide the best care for NF patients. And we welcome not only neurofibromatosis type 1, which is the most common of the phacomatosis, but also NF2 and schwannomatosis. So as you all know, it's the neurofibromatosis is a set of genetic conditions affecting multiple organ systems, not only the nervous system, which comprises the brain, the spinal cord, the peripheral nerves, but also the bones, the skin, the eyes, the ears. And we have the 3 types, NF1, NF2, and the schwannomatosis, which is more rare. NF1 is the most common hereditary neurologic condition and affects approximately 1 in 3,000 individuals worldwide. So the NF1 patients, they may develop the skin lesions, the well-known cafe au lait spots. They are benign lesions, they don't become cancer or tumors. Inguinal freckling, axillary freckling, peripheral nerve tumors, which are known as the neurofibromas, the small, tiny tumors, benign tumors. Also optic nerve tumors, we call them optic nerve gliomas. But they also may develop when, especially when they're transitioning to adulthood, blood pressure issues, attention deficit disorders, depression, bone deformities, and brain tumors, benign and malignant. This process usually starts in late childhood to teenage years. So that's why it's important to not stop care and follow-up once the child becomes an adult. So we usually follow these patients on a yearly basis at least, and we usually do that with, besides the patient following with a primary care provider, we recommend that this patient sees a specialist, a neurologist, or a neuro-oncologist, such as me, for yearly checkups, and we usually do that depending on the burden of the disease. We usually recommend a yearly MRI of the brain. So as I said, the majority of the NF1 related tumors are benign, and the most common one that we see are the neurofibromas. Some people have more than some patients have more neurofibromas than others. Neurofibromas may be completely asymptomatic in some patients, and may be very symptomatic and bothersome in other patients to the point that they require surgical resection. These neurofibromas, they may increase in number, especially throughout puberty and also during pregnancy in case of women. They tend to continue to develop throughout adulthood, and that's why it's important for us to follow these patients at least on a yearly basis. Malignant tumors or cancer are very rare, but they also may exist. So neurofibromatosis type 1 patients, they have increased risk of developing such tumors. The most common of them are the malignant peripheral nerve sheath tumor. It's a mouthful. They are the ones that develop, in the skin or underneath the skin, and they arise from the nerve sheath region, and also gliomas, which are primary brain tumors. They also, they usually derive from previously benign tumors, but they may also be completely new tumors. So unfortunately, we can't predict how the course of the disease is going to be for our different patients. Some of them, the disease stabilize as they migrate into adulthood, and some of them, they continue to develop neurofibromas or plexiform neurofibromas. And we cannot predict which tumors or what tumors are going to become malignant. We know that the exposure to radiotherapy has been the only predisposing factor linked to this malignant transformation of previously benign tumors in NF1 patients. And we also know that coffee, food, smoking, sun exposure, it hasn't been linked to, it hasn't been a risk factor for malignant transformation. So what are some of the challenges that we find in NF1 patients, adults, in the adult world? So it's that, as I said, the neurofibromas, they may be very painful in some patients, and they require special attention. They are specifically bothersome when they are found in areas around the bra line, or the belt, or ankles and foot, or areas of contact, foot and hands. There is also the psychosocial impact that was previously been dissecated here very well by our past presenters, including some impact in self-esteem and relationships and social interactions. The plexiform neurofibromas are rare, but we find it in about 20 to 50% of NF1 patients. They arrive in a group of nerves underneath the skin, and they are known for this finding of bag of worms. So they feel like jelly underneath the skin, and they are usually big. So here we have an example of a plexiform neurofibroma around the ankle, and as you may predict, it's painful when it's in an area that this unfortunate patient is constantly stepping on it. They may affect any area pretty much of the body, and they may cause deformities. So as I said, they develop underneath the skin and deep muscle, but also in areas that we cannot see, like inside our bellies or thoracic cavity. They may compress organs, therefore, and nerves and vessels, and may cause pain, disfigurement, functional impairment as well. They also may have an impact in mood, depression, anxiety, and other psychosocial skills, and they potentially may become malignant up to 20%. So that's why close monitoring is key and that's why we have to follow these patients. And this, depending on the size and where the tumor is found, it may be amenable for surgical resection, or in some cases in chemotherapy, even though we don't have an FDA-approved treatment for such tumors yet. And you may also interrupt me if you have any questions throughout my lecture. Yes?
Do they have a tendency to grow? Andrew has one on his foot that as he's gotten older seems to have gotten bigger, but I don't know if it's because he has gotten bigger and it has kind of grown with him, or if it's actually growing.
Right, so they tend to grow. Some of them tend to stabilize, but they tend not to go away, to regress. So they do tend to grow when they appear. And the highest rate of growth is seen during teenage years and also during changes in hormones. So that's why during pregnancy it's very important that we keep close follow-up, because they may grow during this imbalance or changes in hormone levels. So they do tend to grow. Another very common tumor that is found in NF1 patients are the optic nerve gliomas. They are more commonly found in children, and then they carry on this tumor into adulthood. Sometimes they are asymptomatic, so even though you have this tumor affecting the nerve of your eye, you may not have any impairment in your vision, and sometimes these types of tumors are stable for a very long time and we don't have to do anything about it. But sometimes they may grow and they may require treatment. There are also the brain tumors, or what we call the gliomas. They are more common in adults, and they do require treatment, and the treatment is directed to where the tumor is located and what type of symptoms it's caused, and whether it's amenable for resection or only for chemotherapy or radiation therapy. Signs of brain tumor can be nearly any type of neurologic symptom, such as headaches or seizures or weakness in the extremities, numbness, cognitive decline, you name it. But they're still very rarely found in NF1 patients. Other medical conditions that we tend to see or monitor, at least in NF patients, are high blood pressure or hypertension, risk of stroke, specifically the ischemic type, not so much the hemorrhagic, chronic pain syndrome, including back, joints, hands, and feet, that are associated or not with the neurofibromas, and bone problems, so low vitamin D levels and spine degeneration, which can cause chronic pain and other neurologic symptoms. It's also important, and this is an area that is growing in the field of neurofibromatosis, to talk about fertility and family planning. So as you grow, and you become more independent, you also want to invest in your own family. So females with NF1, they may have more difficulty to get pregnant, and the NF lesions may get worse, as I said, because of this hormonal imbalance during pregnancy. And as we may already know, NF1 is a hereditary condition. So there's a 50-50% chance of your kid to develop or to have inherited the NF1 gene. Counseling, therefore, and genetic testing are recommended for some of these patients, and planned pregnancy and parenthood is also recommended. And we offer these services in the adult world. Clinical trials. So I believe it's the next topic that we're going to be talking about, some research. So I'm not going to touch base too much about it, but currently, unfortunately, we don't have drugs that have been FDA approved for the treatment of the neurofibromas or the plexiform neurofibromas. We have some research being conducted, especially at NIH, the National Institute of Health in Washington, D.C. But here we may also use some drugs off-label for the treatment of some inoperable plexiform neurofibromas that are not amenable to surgery. And there, as I said, there's currently several studies being conducted in other larger institutions such as MD Anderson and Memorial Sloan Kettering in New York, and the NIH itself for the treatment of specifically the plexiform neurofibromas. They are the ones that they are benign, but they have the risk of becoming malignant. This is a good website to keep in mind, clinicaltrials.gov. This website is run by the NIH, and it's where you can find all the available trials, the ones that have already been concluded, the ones that are ongoing, and also the ones that are coming up in the future for the treatment of whatever type of cancer that you may have questions about, including the ones related to neurofibromatosis type 1. So clinicaltrials.gov. It's very user-friendly. You type neurofibromatosis and then they give you a list of all the institutions and trials that are offered for this type of cancer, or this type of condition, I should say. So although there is no cure for a neurofibromatosis, this condition is manageable, and one can carry on a very good quality of life despite having it. NF1 doesn't define you, you define who you are. And we are across the street, literally, to help you deal with your health needs and concerns and questions about the neurofibromatosis. So come say hi to us. Any questions?
We're glad to have you here.
Good afternoon, everyone. My name is Katie Bakovich. I'm a nurse practitioner in the genetics clinic, and I also see patients in the NF clinic. So I have the pleasure today to introduce you to Dr. Donald Basil. He received his medical degree from the University of Witwatersrand, South Africa in 1994. He completed a residency in pediatrics at the Red Cross War Memorial Children's Hospital, Cape Town, South Africa, and did a fellowship in medical genetics at Oregon Health and Sciences University in Portland, Oregon in 2010. Dr. Basil is board certified in clinical genetics. Dr. Basil joined the Medical College of Wisconsin faculty in 2010. He is the co-director of the NF Rasopathy Center at Children's Hospital of Wisconsin. He is also deeply involved in skeletal dysplasia disorders and has published peer-reviewed articles. Currently, Dr. Basil is the section chief of genetics in the Department of Pediatrics and is the program director of the Medical Genetics Residency Program in MCWAH. So, welcome.
Thanks all for having me. I know this time is critical, so we're going to spend at least 3 hours. No, in truth, I'm going to let you get to lunch pretty quickly. So I thought I'd talk about clinical trials, and as I started looking through clinical trials, there are so many trials that are ongoing that I didn't think it was valuable to list everything there. And I thought what would be a better idea is to review what clinical research really is. I think a lot of people hear this word clinical trial, clinical research, but really what does it mean and what does it mean to us? How do we get involved? So what I thought I would do is rehash some of this that we did. I think we did this in 2011. So if any of you were here in 2011, there's some repetition here. And then I thought I'd just recap what we're doing locally just to give you a sense of where we are and what else is coming down. So, there you go. So these are sort of the broad topics that I'm going to cover. What are clinical trials? Where can this information be found? Why is it important to participate? Who can participate and what is involved in participation? So very broadly, clinical trials are research studies that use human volunteers to study the efficacy of an intervention. That can be a drug, that can be a procedure. It can also just be a natural history study in terms of seeing how things progress. But usually there's an element of study involved, and it's usually a human subject that's being involved. So it can be a device, drug, vaccine, anything along that line. We've already heard about clinicaltrials.gov. I quickly did a scan yesterday, and there are 196 studies that are listed on clinicaltrials.gov when you type in neurofibromatosis. Running through those, they're not all NF1, and some of them branch into some of the other neurocutaneous disorders that sort of generally fall under the auspices. So you'll recognize that our clinic is not called a neurofibromatosis clinic. It's called a neurofibromatosis and rhapsopathies clinic. And we could even expand that to other things, because we see children with tuberous sclerosis. We see other neurocutaneous disorders aside from just neurofibromatosis, although neurofibromatosis tends to be our primary focus. So when you do some of these searches and you type in, even if you type in neurofibromatosis, not every single trial is going to be specifically relevant to the condition that you might be interested in. So it's important to obviously read the content of what's there. But it is extremely easy to navigate. You can see here, it says here, not yet recruiting. So if this is something that you were interested in, you could then go and look at that and say, okay, when is this trial starting? Where is it starting? Who are the key people that I need to contact in order to get involved in this trial? If it says completed, obviously they're not recruiting patients anymore. And then if it says has results, it means that there's actually data out there that is publicly accessible that you might be able to find out about that particular trial. So there's a lot of information you can glean off of clinicaltrials.gov, and a very useful site. It's my primary source of it's my primary resource if I'm looking for studies that are ongoing with any particular disorder. So of those 196 trials, several of them are medication trials. We've heard that medications haven't been that effective historically. There's some very newer medications that we're pretty excited about that are showing much more promise. There are several natural history studies going. And what I was interested to find was that there are several self-reported quality of life studies that are ongoing. And it's something we often ask ourselves, that we don't have the data, we don't have this natural history data of how people transition. How did they find themselves going from childhood through to adulthood? And it was really, really encouraging to see that there are studies out there where it's just an online questionnaire. People can log on into that data, participate in the trial, and actually provide that data so that we have more information to be able to help you. So why participate? I think I've sort of brushed on this briefly. Again, one is to contribute to medical research. The other is to get access to things that might not be accessible generally. So a lot of these medications don't even have names yet. They just have numbers. The drug companies are developing them. The only way you can get access to a medication like that, which could potentially have a positive impact, is by participating in a trial. Obviously, it's not globally accessible to everybody, because some of these trials require you to be at the trial center. And if you're not at a trial center, you need to get there. And obviously, that in itself can be a burden just from a accessibility perspective. Who can participate? Generally, trials are written very specifically. They're very, very strict inclusion and very strict exclusion criteria. And that is to protect you. There are bodies within an organization, within every organization, that are specifically set up to protect the patients. If there was no law to that, there could be a lot of research which perhaps wasn't in the best interest of the patients. And especially when industry gets involved and money gets involved, things can be construed as not having the Hippocratic aim of trying to help and doing no harm. There are always inclusion criteria in terms of age, gender, stage of the disease, and then often the other medical conditions relate to exclusion elements that prevent people from participating in a study. So what's involved in a study? And obviously it really depends on what the study is. If we take Dr. Bonnie Klein-Tasman's study, for example, that's doing neuropsychological testing. It's not really an intervention study, it's really a data acquisition study to see how things develop from over different age periods. Now, that's not to say that data from that study cannot be utilized to intervene. And one of the things that I've been particularly encouraged by is the communication that happens with studies like that. So if there is an area that needs intervention, that is usually communicated to the treating team so that those interventions can be facilitated. I think we've covered some of these things. The travel, the additional medical tests that may be involved, additional doctor visits, and usually frequent contact with non-physicians. There's a lot of work that's done by the research coordinators, so you end up getting to know the research coordinators for studies pretty well. Depending on the study itself, some of the studies are really well funded. They'll fly you to the NIH and pay for all accommodation while things are being done. Some studies are not that well funded and they require people to actually get to the destination in order to participate in that study. So it's always important to read what the study entails and what sort of burden is being asked of you versus how much is going to be taken on by the study group itself. What are the benefits and risks? Again, the benefits are to gain access to therapies or modalities that aren't otherwise available, to really have the ability to come in close contact with true experts in the field of that particular area of research, and then obviously contribute to the medical knowledge so that can help future generations. The risks, from a side effect perspective, if you're on a medication that has a side effect profile, you could suffer from the side effects of that medication. The flip to that is that you could be on a placebo and be taking a non-drug for the period of the trial and not have any side effects, but also have no benefit at all, but yet still have to participate in that trial. Most trials where they have a placebo-controlled study will flip over that at the end of that placebo trial phase, you will then be guaranteed to go on active drug if it's been shown to be effective. So it's not necessarily a complete negative, but for the time of that study, there is no benefit. Now the importance of that is it's very important for us to be able to do randomized control studies, because if we just stuck everybody on drug, we really wouldn't know what the effect of that specific controlled population was who didn't get the medication over the same time period. So to really make an accurate and thorough scientific evaluation of what we're testing, there often needs to be those things, and they're called RCTs, or randomized controlled studies. And then obviously the time and all the other things that go into the commitment of actually participating in a trial. So I thought I'd quickly touch on what we're doing here actively at the moment. Dr. Bonnie Klein-Tasman updated you with some of the studies that she was doing. We've had a great collaborative relationship for the last couple of years, and I think it's been really beneficial to us as a clinic service as well as the population that we serve. We currently have an off-label drug extension of one of the MEK inhibitors for inoperable plexiform neurofibromas, and that's really just come on board in the last 3 to 4 months. It's taken us over a year to get this going, but we're pretty excited about having that here. And then 2 years ago, Dr. Olaz gave you an update of the treatment of the cutaneous neurofibromas with PDT, which is the photodynamic therapy. And I thought I'd just dig into that a little bit more deeply because we've had some exciting developments over the last couple of weeks. So just to sort of recap, photodynamic therapy is a mechanism of taking a light source and activating a drug. We use aminolevulinic acid, or ALA, which we put on top of the tumors. We then activate it with a light source, and it becomes toxic to the cells, and then those cells theoretically die, and we're hoping to cure cutaneous neurofibromas. So this is what the light source looks like. This is early stage of in process of treatment, what it looks like after treatment, and then what the drug had, the effect that the drug had on the different surface neurofibromas. What we found in adults is that these tumors, although they resolve a little bit over time, so they shrink away, and telling us that the therapy is effective, they don't completely go away. And the reason for that is that as these neurofibromas grow, they actually have a connective tissue element to it. So there's collagen and all sorts of other tissues in there that are not the peripheral nerve sheath cells. So we can destroy the peripheral nerve sheath cells, but we cannot destroy the connective tissue. So you're still left with something there, which our goal is obviously to make it go away completely. So as a result of this initial trial, we decided to look at children. So looking at neurofibromas, the cutaneous neurofibromas, in a very early stage. So when they're just underneath the skin before they've actually become growths, how do we treat those? And what I forget how many patients we've had through, but probably about half a dozen so far. The biggest challenge we have is how do we monitor the growth and effectiveness of our intervention. We've been using photographs of the skin and trying to measure the outside diameter, but that's really not effective for a growth that is primarily under the skin. So the exciting thing that's come about is we found this ultrasound machine that uses high frequency ultrasound. So this is not your common garden ultrasound machine. This is a specific research developed ultrasound machine that uses very high frequency, and what it allows us to do is see just underneath the skin. And I thought I'd show you an example of what that looks like. So this is the surface of the skin, and this is a very early neurofibroma that's just growing underneath the skin. This one here has had a little bit of a growth on the outside of the skin, but you can see there's the bump on the top of the skin, but the neurofibroma actually goes all the way down to here. So our aim is to rewrite our protocol, which didn't allow for this particular machine to be used, so that we can now really look at how good is this therapy going to be in getting rid of all of these elements. So the study is pretty much the same concept, where we put the drug into the skin. At the moment we're using just a needle device that actually penetrates into the skin to allow the drug to penetrate. We're looking at other options. Obviously, doing that for every single lesion is pretty cumbersome. So we've been thinking about how can we think outside of the box. Kids run around in the summer in the sun all the time. What if we made little discs that had the drug on it that could be pushed into one of these things, caught sunlight, concentrated the sunlight, and used the light from the sunlight to activate the lesion? So we're thinking about all of these types of things to try and develop a system of therapy that would be effective across the board. I'm really encouraged by the preliminary data that we have, that this technique works. It's just how do we implement it globally so that this can be an easy treatment for everybody. All right, and with that, enjoy your lunch.
Diana Haberkamp from NF Midwest, the Executive Director.
I gotta do that. I gotta do the robot ragdoll thing. See if that helps me, since I didn't really prepare a whole lot. I'm Diana Haberkamp. I'm the Executive Director of Neurofibromatosis Midwest. We've been around for over 35 years. We started in 1981. I've been involved for about 20 years now. Personally, I do have 2 children who are adults. That time just flew by. And my husband has NF type 1. So our mission is basically to improve the lives of people with neurofibromatosis in the Midwest region. So we cover 6 states. See if I can get through them here: Indiana, Illinois, Iowa, Kentucky, Wisconsin, and part of Missouri. We've started following kind of this acronym of CARES, which tells you a little bit about what we try to work on. It's C for clinics. We work with the clinics. We now have a care and outreach coordinator who works with the clinics along with the community to just help be a liaison to the community. We just started a program. Nobody's applied for it yet, but we started a care impact program where we want to give funds to the clinics or other people in the community who want to do things to improve care. It's a wide range of things that they can come up with to improve care. A is for awareness. We do whatever we can to improve awareness. We have a lot of swag. People seem to like the swag. They always want different shirts. But we also work with people in the community who want to, get in the media. We have our walks, which also creates a lot of awareness. R is for research. In research, we've been funding research for 35 years. Now we focus more on, we focus on a little bit more kind of closer to the bedside or I guess data acquisition researcher you're talking about. We funded Bonnie Klein Tasman for many years now. Things that can kind of help the community in a more immediate way, giving them some information. Also, we focus more on funding locally. We're going to start a program of raising funds to help with clinical trials now that we're seeing that, yay. My daughter was actually in one, so I know the benefit of those. Where we want to help people, help the clinical trials locally, because sometimes they're not receiving enough funds to even, they have some of the funds, but they don't have enough for research coordinators and some of the other things. We also work, in terms of research, we do a lot with advocacy. Littlest Tumor Foundation, Tracy Wharton is great at that, and we work with her a lot. We work with NF Network, too, and we go to DC and represent our areas. And then E and S are for education and for support, so that all spells care. Education and support are probably, I think, the most important thing. Certainly as I've raise my kids, I'm always thinking of the knowledge that I've learned over the years that I wish I knew, and we're always trying to impart that on people. Everybody, in terms of our staff, we have 1 full-time and 3 part-time employees, but everybody has a personal interest in NF. Everybody is affected, either affected or has a loved one affected. And education and sport is just so important. So we really, really focus on that, and I think that's important to have that locally. We work with, I do want to correct Lauren, I'm sorry Lauren, we're working with you, but we're not NF Network. I know this is confusing to people. We used to be a part of the NF Network, but we're not. We focus on our area. We work with CTF. We work with Littlest Tumor Foundation. We work with NF Network, but NF Midwest has been for several years an independent organization that's not affiliated with one unit, one organization. We're working with all of them. So we have a project we're working on with CTF and NF Network and Texas and NF Northeast that is hopefully coming out soon. We've been working with Heather a lot on that. And like I said, Lauren said, we're working on things with them. So that's the beauty of it. We're seeing a lot of this collaboration. Anyways, does anybody have any questions? No? That's it. Are you gonna, I don't have to introduce anybody, do I? No? Okay.
Although as all the support groups kind of work with each other, here we have Heather Brecky. Heather's from the Children's Tumor Foundation. Heather also is a part-time genetic counselor in the clinic here at Children's.
Thank you. Thanks everyone for being here. I think I'm the last one of the day, so and in my usual fashion, I'm probably a little too formal, but I do have a presentation here. Just so I don't forget anything. And okay, so Thanks, Lisa. As is mentioned, I'm both clinical and I work with the Children's Tumor Foundation. So right now I have my CTF hat on. But if you bump into me on the street, I may be wearing all three, just depending what you want to talk to me about. So I'm going to talk about the Children's Tumor Foundation. We've been around for a while. This year we're celebrating our 40th anniversary, which is very exciting. Many of you may know us previously as the National NF Foundation, and NFF. Our name was changed. We serve both children and adults with NF type 1, NF type 2, and schwannomatosis. One of the things that has been very exciting is the last 9 years we've received the highest 4-star charity rating from Charity Navigator, which looks at different organizations, where their money goes, how transparent it is, making sure money goes the right place. So we're pretty happy with that. One thing I'm going to kind of focus on as far as CTF goes is kind of our general mission: drive research, expand knowledge, and advance care for the NF community. So driving research, we fund various areas of research. Clinicians and basic science researchers can apply for awards through CTF. Most of our money gets funneled into research. And we were part of the early funding that went into the MEK inhibitor trial with the photo on the bottom with the plexiform neurofibroma decrease in size. These results have been tremendous, and so it's very exciting in the field of NF to be able to have some medications that are actually making a big difference for people in pain and growth of tumors and function. So we encourage collaborations with different researchers and scientists. We believe generally in data sharing, so not kind of hoarding their results, but actually having researchers and scientists share results with each other, because then it can move things forward quicker. We help with research by recruiting patients through the patient registry, and we also, with the other groups, go to Washington to do some lobbying to try to get more funding from legislature and NF research. Whoops. So expanding knowledge, we fund clinics to be able to offer conferences like this, and we also offer on our website different videos and brochures. Some of them are out on the table out there, or you can go to our website to see some of the more recent ones. And then once a year we have a family forum that's somewhere throughout the country. This year it was in Atlanta. Next year it's going to be in San Francisco. It's a great opportunity. Hundreds of people from throughout the country with the different NF diagnoses meet people, have fun, kids activities. They bring in speakers from all over the world to educate you about NF. So it's a great opportunity if you ever get a chance to go. And then advanced care, this is kind of my area of what I do for CTF, is working with the NF Clinic Network. The clinic network, it consists of 55 clinics throughout the country who have applied and been accepted to be part of our network. So Children's Hospital of Wisconsin has been involved in the network since its inception. And so that's a big kudos to the clinic here, showing that they demonstrate multidisciplinary care. They have dedicated providers, very good clinic here. We're trying to expand that as well, with the goal kind of to make sure that all clinicians are familiar with NF, are up to date on all of the recent research, so that in the end families get the best care that they need. And so we have other types of activities. The NF Conference is a once-a-year conference for researchers and clinicians, and people from around the world attend that conference, and it's a 4-day crash course on anything related to NF you can even imagine. And it's really a neat thing to see, everybody devoted to improving lives of people with NF. Through our organization, we've also developed a mentorship program to kind of get clinicians to interact with each other, share experiences, and kind of, again, try to get quality care and continue to improve care. So kind of talk just, the three groups have kind of talked to you about what each of us do, but in the spirit of the transition conference that we're at today, I'd also like to pose to you kind of what kinds of things you can do to benefit the most from being, to benefit the most. As you go through these important life transitions, there's things that can be done to help make things easier. So stay informed on things. Some of the earlier talks talked about gut transition, so tracking your medical history, knowing about NF by attending events such as this. All the NF organizations have newsletters you can sign up for to get updates and know what's going on with research. Attend NF events. We have NF walks, NF runs. There's the NF camp and retreat. In fact, we do have a Milwaukee NF walk that's tomorrow. If anyone can go, feel free to show up. We would love to see you there. It's up in Grafton. And then, of course, obviously, always go to your NF doctor and your NF clinic, because that is the best way to stay informed, not just on your specific individual symptoms, but also as the doctors learn more about NF, they can make sure you're aware of it. As recommendations change for clinical management, they'll be on top of it. So very important to continue to follow. And then also just get involved, starting a fundraiser, volunteering, joining some of the social media groups, just to kind of meet others and feel part of the community. So, you know, I think in a lot of people that I've worked with NF, there's a lot of feeling of isolation, that I'm the only one that I know has this. And so I think reaching out to others and connecting with other individuals who've maybe not gone through the same exact thing as you, but similar things or similar fears, I think can be so empowering. Knowledge is power, and I think, you know, the more you can learn, the more you can get involved. I think it's great. We have a patient engagement program through CTF where patients can be involved from the very early process of research development, and so they can be involved in what do those researchers want to look at, what's important to the families before we figure out what's our most important outcome of the study. And so that's a possibility people could get involved with. And then the NF registry, if nobody's heard of that, I can fill you more in over lunch, but basically it's a database of over 8,000 people who have NF, and it's a way that we do two things. We track individuals with NF and their natural history, so you put in your clinical symptoms and we have you update it once a year so we can see how symptoms change with age, and that gives us a lot of information about NF. And then secondly, you sign up and you can opt in to receive emails from researchers. And the researchers, well, basically you're getting a generic email that says, hey, you might qualify for this study. You can review the study, take it to your doctor, and then decide whether you want to participate in that study. So similar to what Dr. Basil was saying, it might be a medication trial, it might be a survey, a quality of life, it might be some type of intervention. Now they're doing like Skype, coping strategies, so there's many different things that you could potentially be involved in. So I encourage if you want to get more involved, there's so many different ways between, you know, CTF and NF Midwest and LTF. I think there's just a lot of different opportunities that I hope you'll take advantage of, because I think that that's very empowering for people, especially at a young age, changing into adulthood, to empower themselves and be part of the NF community. Okay, so I mentioned the walk tomorrow. I hope you'll consider attending. Thank you so much, and I think all of us will be out by lunch if anyone has any questions about any of our groups. So thank you.
I want to thank again all the presenters, and some are still here, for bringing all your expertise to us on a Saturday morning. We know you're all busy, and we appreciate that. And to all the attendees, you also, you know, brought yourselves here on a Saturday morning, and we're really glad you did.